Your life, ma'am.
A very good evening to one and all of you for our AIOS ARC PG update webinar on glaucoma case and concept festivals. I think we have to be truly honored to have the real experts with us today. And of course, not just the expert panel and the top-notch speakers whom we have. And I'm sure it's going to be an explosion of information, and I'm so looking forward to a great webinar today. We have with us on the expert panel, Professor Sushmita Kaushik, who's a professor of the Department of Ophthalmology and a very eminent personality. I truly believe she's a knowledge bank who is going to guide us most capably through this webinar. We are lucky to have with us Dr. Tanuj Dada, who's again Professor of Ophthalmology, RP Center, and an individual of great standing in Indian ophthalmology and world ophthalmology. We have with us Dr. Vinay Nangia, who's the chairman of the Suraj Eye Institute, Nagpur, glaucoma specialist and retina specialist combined, a highly respected glaucomatologist of our country with awards and accolades to his attribute. We have with us Dr. Chandrima Paul, who's the director and consultant glaucoma services at BBI Foundation, Kolkata. He's the honorary general secretary of GSI, a very driven GSI for all of us, secretary for all of us. We are truly lucky to have with us Dr. Lingam Vijaya, who's a senior consultant at Medical Research Foundation, Chennai, one of the most eminent personalities in glaucoma world over, and again has the most amazing lists of awards and accolades to her attribute. We have with us Dr. Sunita Dubey, who heads the glaucoma clinic at Dr. Shroff's Charity Eye Hospital, a highly prolific surgeon. Some of the most outstanding glaucoma surgeries I have seen being done with her, and has a high standing in the field of ophthalmology in our country. I consider myself truly lucky to have with me as co-moderator Dr. Shailesh, who's a senior consultant at Shekhar Eye Hospital, Bangalore, with a huge experience in glaucoma, cataract, and squint. And I'm very much respected glaucomatologist of our country, and I'm sure he's going to keep the whole webinar on fire in the next 2.5 hours. So without ado, we shall go on to the different typical case presentations, and which should cover the entire gamut of glaucoma. And we have with us Dr. Mayuri Kamar, who is the glaucoma consultant at Okra Eye Care and Research Center, Ahmedabad, with a 30-year-odd experience in glaucoma, and has held very important posts in prestigious groups like the All Gujarat Ophthalmic Society as a vice president. And she is going to tell us about her very interesting case, a patient with end-stage advanced open-angle glaucoma. On to you, Dr. Mayuri. Would you share your screen?
Yes. Is it visible?
Yeah.
Yeah. Full screen.
Okay. In the next 6 minutes, I will try to cover 2 cases of mine, how we treated, which are advanced case of open angle. We all have seen such advanced cases with the 0.9 CDR, pale disc, and the very small tubular island. And we think that this is not, it's a hopeless thing, but it is not so. You can see from these 2 fields that we can control or monitor glaucoma, and patient can have a good vision or useful vision all throughout their life. These are the patients who are at a high risk of progression, and very low margin of the play is there. But the aim here is to how best we can improve the vision in these patients. It is also difficult to monitor this patient as the imaging fails because of the poor floor effect, and the visual fields cannot be used a routine field, but you can use the 10-degree program or the macula program. And if vision is too much less, then you can use the large size stimulus. And they need frequent monitoring. Visual field should be repeated 3 to 4 months, and it can have a high variability also. And these are the list of the risk factors for the progression in advanced glaucoma. And one has to carefully look at those factors and treat them vigorously. So can we preserve this field in all patients? and that too lifetime? Yes, we can. There are so many studies in the literature which says that by reducing the intraocular pressure less than 13 millimeter of mercury or reducing 40% from the baseline, we can achieve to have a good success in the treatment. Also look at the IOP fluctuation, which is an independent risk factors. Now, how low one can go? And here also, if we go very low, then you can end up with the hypotonic maculopathy. So the therapeutic window of intraocular pressure is quite narrow. And these are the three modalities that we use. But for me, the filtering surgery, if the target is not achieved, could be a better option compared to the others. The medical line of treatment, monotherapy, difficult to achieve, very low. PG analog and ROCK inhibitors, they can reduce the intraocular pressure less than episcleral venous pressure. But with the many combination therapy, now we can achieve the good control of the intraocular pressure. SLT can be of use. It reduces the intraocular pressure by 4 to 6 millimeter of mercury and also reduce the diurnal fluctuation. So patient who is not willing to take the risk of surgery or you want to postpone surgery for some time, you can use this modality. The surgery trabeculectomy should be enhanced with the antimetabolites, and releasable suture is much, which gives you stable chamber on day one. And the tubes, I think Ahmed glaucoma valve is a better option compared to the non-valve options. But the most important thing is frequent counseling of the patient and the relatives regarding the wipeout, or the one has to give injection mannitol preoperatively if the pressure is high, and paracentesis if pressure is still high, then you can do that. And anesthesia, preferably topical or peribulbar if you are giving, avoid the adrenaline and orbital compression. The antimetabolites should be applied over wide area and posteriorly. And the paracentesis gives you slow decompression and the also helpful in maintaining the antechamber all throughout. And the releasable suture is a must in all these patients, and always check the wound integrity at the end of the surgery. So how to monitor? It is very subjective assessment, and the patient response is most important indicator, and the drop in the visual acuity is a sign. Now let me share the case. 80-year male who was on treatment for glaucoma, stable since 8 years, and left eye was lost after the trauma. He was using dorzalimide, timolol, pilocarpine, and brimonidine. And these are the data. Vision improved to 624, left eye chysis bulbi, and you can see the corneal thickness was also good. This was the field done in 2017, which was similar to the previous fields and the OCT. So what we did, we revised the medication and we added the travoprost to the whatever he was using, and the combination therapy was suggested. After 1 week, the AT was 19 millimeter of mercury. So we discussed the possibility of anti-glaucoma surgery, but patient was not being one-eyed, not willing. After 2 years, due to COVID time, he could not come, and he came in the December this last year, and with a severe loss of vision since 3 months, unable to see the food in the plate. So everyone was tense, and the intraocular pressure was 45 with the vision only now 5 meters. And he was already on the oral treatment. So post-mannitol, the intraocular pressure reduced to 28 millimeter of mercury. And these are the perimetry reports, macula size 5 and 10-2 program, very less field. So marked progression, uncontrolled IOP with MMT, one-eyed patient, regular follow-up, not possible. So what to do? We suggested again the trap with a very high risk, and wipeout was explained. This time they were willing to undergo. We did the surgery.
1 minute remaining, ma'am.
Okay. Should I finish?
You have 1 minute left. You can finish.
So the vision was 4 meters unaided on day 1, and we were happy. Now the another patient, 90-year, very old man, gentleman, the daughter is a pathologist in USA. Known case of glaucoma since 20 years, had multiple allergies to the multiple drugs, was using 2 drugs, timolol and latanoprost, and systemic hyperlipidemia. So one eye vision was 636 and the other eye was only counting finger 1/5. temporal, and pseudophakic open angles with the glaucomatous optic atrophy in left eye and the similar change in the other eye. And these are the imaging and the visual fields of that patient. Now, this is the 10-2 program with size 5 stimulus. Target was not achieved and patient refuses surgery. We suggested SL to do this patient and we did it, and the medication was continued, close monitoring was done, and still today, I am seeing this patient. The both eye feels stable, and he is happy and we are also happy. So to conclude, these are the cases at high risk for going the blind, but one has to manage aggressively in these patients, and close monitoring is required for the patients with the risk factors. And incisional surgery offers the best chance of achieving despite some risk. However, one may choose medical or laser therapy in some of these patients. Thank you.
Thank you very much, Dr. Mayuri. I have a question for you, Dr. Shushmita. Would you consider that there is any role of a stage surgery in this end-stage glaucoma, especially if the cataract is not too significant? Would you like to knock it off at the same time, or would you be conservative?
So that would depend. So the usual, the usual thing that we say is that if there is a cataract, which if the patient needs glaucoma surgery and there is significant cataract, then they need to be out. And usually in end-stage disease, one would not like to go in again and again. So if there is a cataract, but a cataract, not a lens extraction. So if there is a significant cataract, yes, we might as well take it out along with the glaucoma surgery.
Dr. Shailesh?
Yeah, we often talk about wipeout phenomenon. I just know all those panelists in this country, how much they face this wipeout phenomenon in end stages. That is the one thing which we always tell the patients, wipeout. Is it really scary? And what are all the indicators which will, who are those high risk people who can go for wipeout?
So I think we've learned that low pressures intraoperatively as well as postoperatively is something that we really need to take care of. And nowadays, I think most of us use viscoelastic substances and a lot of tight suturing with releasable. And frankly, touch wood, the incidence of wipeout is really less, even though we work on one-eyed, very end-stage glaucomas. But it's important to, of course, tell the patient. And interestingly, in all these years, one or two that we've seen, with topical steroids and therapy, they actually do seem to reverse. So it's not such an irreversible thing as well. So interestingly, they did, but the incidence is very low. And I think it's to do with.
I think you need to avoid hypotony at all costs.
Absolutely, at all costs, especially intraoperatively and post-op, no hypotony, then that's the usual thing.
Yeah.
I think the raised pressure also is not a good thing. Any spike in the immediate post-operative period.
Yes.
Shanta has a publication where she has done a prospectively the risk of wipeout. And as I don't remember the exact figures, and it's very low.
Very low, yeah.
Take care of the intraoperative hypotony and also postoperative hypotony and postoperative spike.
Why
and
is
also
it
maybe not operating on a very high pressure eye, use mannitol, see to it that the pressure is reasonable before we enter the eye. I think that also would be important.
Why is vision loss after TRAB supposed to be counted at 3 months on? Why is that so? That probably the early days when the patient's vision actually dropped down significantly in these very advanced eyes, and then over a period of time it builds up. What could be the explanation for that? It is probably the IOP building up?
Possible that the homeostasis gets back, because immediately post-TRAB we do see, and maybe there might be a little bit of macular edema or macular hypotony initially, and with inflammation and with steroids, when all that settles, possibly it comes back. But yes, they do come back with steroids.
One last question, Dr. Tanuj. Are there any tweaks which you would advise in a surgery, something different in these kind of end-stage glaucoma surgeries?
So I think very critical is the anesthesia. So if you can avoid giving large amount of course, retrobulbar should never be given. and avoid giving large amounts of peripurpur that increases in intraorbital pressure, and that can be deleterious to the optic nerve. And that is one of the causal factors for wipeout, not the surgery, but the anesthesia. The second issue is, of course, you operate only on a soft eye. And if there is preoperative, patients are, like Dr. Mayuri showed, on multiple medications, you should stop the medication, give the patient oral Diamox, and give a short period of steroids, maybe 1 week or 10 days, to reduce conjunctival inflammation. That will increase the success of surgery. And during surgery, of course, you can use some viscoelastic. Another option is to use an anterior chamber maintainer. That helps to maintain the AC during surgery, and it also washes off any hyphema or inflammatory mediators released at the time of surgery. And at the end of surgery, you should have a formed AC with releasable sutures, and you should not be in a hurry to take out the releasable in the early postoperative period, because if the eye goes into hypotony, then you will have loss of vision. So I think these are few points which are important for these patients. And mitomycin C should be used 0.4 milligram per ml posteriorly for 2-3 minutes, because you require a low target IOP. Thank you.
I think you've covered it all. Anything else to add, Dr. Nangia, Dr. Chandrima, before we go on to our next speaker?
I mean, I think that everyone has covered a lot of points. It's been very rare for me to have seen a wipeout, and really you end up operating on patients because there's no way out at that late stage. So we've talked of hypotony, and we've talked of elevated intraocular pressure post-operatively. And I think that's the fight that we have, the conflict we have with the eye, to make sure that it's not too low and not too high. So I think the use of mitomycin, being prepared to see the patient very frequently, use massage, use laser suture lysis, use needling as and when required. I think these are all critical to saving the sight in such an eye, actually.
Yes, thank you so much. And yes, Rashmi, we agree with your point too. We shall now go on to our next very eminent speaker, Dr. Vinay Nangia, who is going to be talking on a typical case in angle closure disease.
Okay, you can see my screen?
Yes, yes.
Okay, all right, here we go. Okay, so I'm going to take you through a case of PACG, and every time that I deal with a angle closure glaucoma with elevated intraocular pressure, it's a great challenge trying to figure out what's going to happen to this eye, actually. So this is a male who was 53 years old and came to us with complaints of blurring of vision in both eyes since the past 7 months. And he was on pilocarpine and timolol maleate in both eyes for the past year. The visual acuity was 6.9 in right eye and 6.9 also in the left eye. The anterior segment examination showed a 1 helix grading of 1, and there was posterior synechia and sectoral iris atrophy in the left eye. The intraocular pressure recorded was 15 millimeters of mercury in the right eye and 29 in the left eye, and gonioscopy showed 360 degrees angle closure in both eyes. So these are the anterior segment measurements. The axial length was about 22.23 in the right eye and 22.40 millimeters in the left eye. The CCT was a little on the higher side for our country. The aqueous depth, that is from the posterior surface of the cornea to the anterior surface of the lens, was really shallow. It was about 1.64 and 1.59 right and left eyes. And the lens thickness was on the higher side, being about 4.58 and 4.59. You can see the appearance of the anterior chamber and the anterior segment. You can see the iris bombae in the right eye that is on the left side, and the left eye you can see the pupils are semi-dilated because of the changes in sectoral iris atrophy. So this is the appearance of the optic disc, and you can see we're really dealing with an end stage kind of PACG patient, and there was significant retinal nerve fibrillary loss, and you can see here that in the right eye on the heat map, the GSL only some part of it is still remaining, but you know, the inferotemporal part, which is the part that undergoes maximum damage, that's all gone actually, and the deviation maps also tell you the same thing. And the left eye, you can see that there's even greater damage, even though the eye retains 6/9 vision. So the patient was diagnosed to have primary angular glaucoma, and we advised alpha agonist, beta blockers, and Diamox tablets, and he was not willing to undergo any surgical treatment at this point. He came back 3 months later. The intraocular pressure in the right eye was 24 millimeters of mercury. In the left eye, it had gone up to 60 millimeters of mercury. And then he was advised combined surgery in the left eye. He did undergo left eye cataract surgery and trabeculectomy. And 1 week post combined surgery, the intraocular pressure was 21 millimeters of mercury in the left eye. And then the patient was lost to follow up for this intervening period of 6 weeks, which we think is a very important period for taking care of the eye, actually. So he did come back, and at that time, he also underwent the right eye cataract surgery and trabeculectomy. And the left eye intraocular pressure was found to be 30 millimeters of mercury, and he was put on drops again. On follow-up, in the right eye, he appeared to have developed a flat bleb with an intraocular pressure of 23 millimeters of mercury. And on massage, the intraocular pressure went down, but after an hour, it again came back up to the same levels, actually. So we did bleb needling for the right eye, and that was done on the 24th of December, 2021. Meanwhile, the left eye intraocular pressure was continued to be on the higher side, and that, you know, we did advise him further surgical management. So this is the appearance of the bleb in the right eye. It's the conjunctiva appears to be turning pale, and this is the bleb just post needling. And you can see the anterior segment OCT shows a large gap between the bleb and the sclera, and that is a part integral to the bleb. But the second photograph shows that on the adjoining sides, you know, the bleb architecture in the conjunctiva, the development of the pores that is not yet formed. So we're not quite sure how this bleb is going to do over a period of time, and we're waiting for the patient to come back for a follow-up. And this is the left eye. So what we have is the pale conjunctiva of the scleral flap, and that's because of the mitomycin. And you can see that the anterior segment shows you that there's complete absence of bleb on the OCT, and that goes with the clinical appearance, actually. So, you know, when you do needling, there are various things that happen, you know, under the conjunctiva. And if you take a look at the figure on the top left, this is our patient. There's a pale conjunctiva above the scleral flap, and there is vascularization of the conjunctiva adjacent to it. And when you put a needle under the conjunctiva, you know, what you may expect if the conjunctiva hadn't really stuck to the scleral flap is that the fluid would sort of go underneath the conjunctiva, and then you would lift up the scleral flap. And on the right-hand side, you can see that what can happen when the conjunctiva goes very pale is, and it's stuck to the scleral flap, is that the pressure of the fluid can actually cause micropores to develop in the conjunctiva, allowing the fluid to come out and develop micro leaks. So if one were to do needling, one would have to be extremely cautious in such a patient, actually.
1 minute remaining, sir.
Yes. So this is, you can see here on the top, you can see the lens volt, and that's very classical, although it's a little bit hard to determine exactly the scleral spur because the iris is in contact with the peripheral cornea. And post cataract surgery, you can see what's happened, that he's developed a negative lens volt, and the total change in the lens volt was about 1.75 millimeter, and the aqueous depth also increased significantly to 3.36. So in left eye, the efficacy of lens extraction reducing IOP was more than 30 millimeters of mercury in presence of a non-functioning bleb. So we often say that just removing the lens reduces the intraocular pressure, and we thought that this was an example where the bleb was not functioning, but the pressure reduced by more than 30 millimeters of mercury just because of the lens extraction. The first few weeks are extremely important if one has to deal with the bleb. A significant pale conjunctiva that is stuck to the surface of the sclera is a challenge for safe needling. The needling of the bleb in the right eye helped to reduce intraocular pressure, but the drainage architecture of the conjunctiva has not yet evolved for long-term expectation of successful filtration. And negative lens volt and total change in lens volt after surgery shows, of course, the efficacy of lens extraction in dealing with one of the possible pathologies. Thank you very much.
Thank you very much. Lot of food for thought. But why would a bleb be flat, and when it lifts up with digital massage, could it be that the ostium was blocked and maybe that would have been the issue?
Yeah, I mean, normally, we believe that it's not really the ostium where the primary block takes place, but that it's under the scleral flap actually that the block takes place. And once the fluid stops going out, then the conjunctiva just sort of tends to settle down on the sclera, which is its resting space. So if the fluid is going out of the scleral flap, then it keeps the conjunctiva elevated.
So how soon would you like to do? Would you like to do releasable suture very early, or would you want to intervene with needling right away?
Well, what we tend to do is that it's a stepwise thing. We do a massage and we see if it works. And normally my experience is that massage only tells us that it can be patent, with some pressure. And then we see the patient after another 1.5 hours, and we find out whether the pressure has risen up again, actually. If the pressure has risen up again, then that is an indication to us that you go ahead for laser suture lysis, actually. If the laser suture lysis works for a little while and then stops working after a few days, and that can happen sometimes, then that means that that is an indication that you go for needling. And needling for us is not merely just, sort of freeing up the conjunctiva from the sclera. For us, it's very important that we free the conjunctiva, but very importantly, we also free the scleral flap from the bed, actually, to allow the fluid to come out.
Dr. Shailesh, would you have a question?
Given a choice, that's which one you would like to do, a cataract first or the glaucoma surgery first? Because we know we are dealing with angle closure disease.
Yes.
Number one. Number two, many times we may not have all those very wonderful investigative modalities that you nicely captured, AIOS, OCT and all. So in that situation, what clinical features which would like you to err on side of a surgery or on side of a medical therapy?
So, I think that, we've had this discussion with some of our panelists also. One is that, for example, the left eye, he came with a pressure of 60 millimeters of mercury. He's already undergone iris atrophy and things like that. And, the disc was really 90% cut with so much ganglion cell loss. So at this point, we think that it is much better that you go for a combined surgery. And I do want to tell you that a lot of people think that in combined surgery, it's very hard to get the bleb to work. But in many cases, you can get the bleb to work in combined surgery in primary angle closure glaucoma, actually. And also, therefore, we applied a little bit different rationale for the right eye when we did a combined surgery, that the cupping was very significant. And, we saw what had happened to the left eye. And we thought it was probably good to, opt for a combined surgery also in the right eye. So I think that I also tried to explain that, that just simply cataract surgery in the left eye would have helped us to reduce the pressure by about 30 millimeters of mercury. That's a retrospective assessment based on the intraocular pressure on treatment post-operatively compared to the intraocular pressure on treatment pre-operatively, in presence of a non-functioning bleb. So there is scope for doing a trabeculectomy and a cataract surgery combined in such patients, actually.
Dr. Shushmita, I have a question for you. Would you think of even doing a clear lens extraction, if at all, or a very early lens when in an angle closure disease along with trab? Because if you've just done a trab alone, the post-operatively, sometimes some of these eyes, the AC tends to be quite shallow, and it makes the cataract surgery even more challenging. So what are your thoughts on that?
Yeah, so if the pressures are, say, it will also depend on the anterior chamber depth. So there are, for instance, cases like an anophthalmos or a very small axial length with a very, very shallow AC, probably we would make an exception. But usually we don't need to actually take out a clear lens so early in the disease. And by the time there is chronic angle closure causing about 50-60 millimeters of mercury, it's the trabecular meshwork which is damaged, and chronic angle closure does cause a lot of trabecular meshwork damage. So simply removing a clear lens, I don't think would, but probably if it was really shallow and we thought that doing only a trab would compromise it, you might, but a clear lens extraction, at least I've never done it. I've never had a cause to do it. So I don't think it would be required. Depends on the glaucoma completely. Yeah.
Sorry, Dr. Shailesh, I'm going to take one question before I ask you today. Dr. Tanuj or Dr. Vijaya, what is the role of cataract extraction in a phacomorphic glaucoma? What would you all feel like? What would be would there be any extra special measures, or when would you decide to do a trab also in these cases?
I think a phacomorphic glaucoma, definitely cataract extraction would be the go-to procedure, and you have to preoperatively reduce the IOP and start the patient on steroids. And of course, the expertise for cataract surgery increases because when you open the capsule, you can have a extension of rhexis. So preoperatively, you can reduce the intralenticular pressure by doing aspiration with a needle, and then proceed with a phacomulsification using a dispersive viscoelastic to protect the corneal endothelium. And I think most of these patients do well after cataract surgery, although you need to give a lot of topical medical therapy in the post-operative period to control the IOP. And if you find that there is advanced cupping after surgery or the IOP is not controlled medically, then I would do sequentially later on as a second stage, do a trabeculectomy.
Yes. Yes, because yes, no, it doesn't make sense to operate on a hot eye. And if it is actually just an appositional closure, or if it's just that there is still synechiae is not closed more than 180 degrees. So we could do away without doing a trab too in these eyes. Any thoughts on this, Dr. Vijaya?
Yeah, I think the phacomorphic cataract glaucoma is mainly because of the cataract. I don't think there is a need for the trabeculectomy. And basically, as long as you're missing out on any angle closure glaucoma in that. Otherwise, just removing the cataract, and as Tanuj has put it correctly, and doing a phacomulsification. The trick for doing the phacomulsification is to stain the capsule and debulk the lens before starting the capsular rhexis. Once the rhexis comes out well, the surgery can be simple. So they don't need trabeculectomy. So better not to do a trabeculectomy along with the phacomorphic glaucoma.
Dr. Shailesh?
Yeah, sir, Dr. Nangia sir has nicely told about the needling part, but how to have a controlled needling, like Dr. Tanuj had nicely shown in papers like AIOS based needling, because we have to do a proper needling and a very extensive needling at times if you have fibrosis. Any experience with that, sir?
You know, every case of needling, you know, it appears to be a challenge because, you know, half of the time you're not really able to see, you know, where your needle is actually.
Exactly.
And it's, so you don't know where the conjunctiva is stuck, where it's really thin, where it's going to give way. And then a greater challenge is really to find the edges. If you're not able to see the edges of the scleral flap and you want to go under the scleral flap, then that is a real. So that's something that you tend to sort of, you know, feel with the needle actually, that when you find a rough edge of the scleral flap, if you're not able to see it, of course, if you're able to see it and the conjunctiva comes to your aid, then of course, you know, things are relatively easy actually.
Dr. Tanuj sir, you had experience on that AIOS based. Are you still following that procedure?
See, I think that is a solution that is only possible in high-tech centers. It's a very expensive, you know, we used to have both the OCT guided slit lamp on the OCT, and of course we have microscope with OCT, but I don't think that is required for regular needling. So I think that has to be done under the observation of the microscope. And if the needling the conjunctiva for an encysted bleb is quite easy, but once you have a scenario where Dr. Nangia showed when the scleral flap is fibrosed, that requires a lot of expertise. And unless you see the scleral flap under the microscope, I think it can be a blind procedure and it may lead to hemorrhage and adverse outcomes. Another option is to do a reverse needling. That is, you know, ab interno, you can do with a like a bimanual with irrigation and with the intraoperative gonioscope. You can visualize the ostium and you can do a bit of needling there if the ostium is stuck, or you can even put in the instrument and raise the flap, especially if it is like 6 weeks or in the early postoperative period. So that is another option if the under the microscope, the scleral flap is not visible. But on the whole, if you see the long-term prognosis after scleral flap is fibrosed, the long-term prognosis of needling is not good. So these flaps tend to fail. And one more point, I think when you do needling alone, that may not be sufficient. You have to give some antifibrotic therapy along with needling, such as 5-fluorouracil or diluted mitomycin C, because it's a failing bleb. So just maybe plain needling may not be sufficient. Thank you.
Dr. Shushmita, what would be a follow-up schedule post YAG-PI? Like, would you believe there's a role of ASOCT, and what would be the most important index which you would see on ASOCT?
Okay, so just one comment about the needling. I'll just finish that. So clinically, we've also seen that if the needling works best if there is fluid under the scleral flap, because usually it's not a nice thing to go blindly under the scleral flap. Usually the needlings are done subtenons. And if on gonioscopy, you can see fish mouthing of the sclerostomy, we found that to be a very good indicator of some fluid under the scleral flap, and those blebs are likely to do better than those in which it's just a straight line, which means there's no fluid going into the underneath the scleral flap, and doing a subtenons needling in those cases isn't going to work. So that's just one small caveat. Okay, regarding the post-op follow-up of YAG-PI, of course, we need to see the intraocular pressure, of course, and the patency of the YAG-PI. That's the first thing. We don't usually use an ASOCT either pre or post. It's all gonioscopy based. And post YAG-PI, it's very important to do a gonioscopy and see to what extent the angle has opened up. But the easiest clinical indicator would be the intraocular pressure. And the two things that to look for if the IOP is not controlled is the patency of the PI and whether there's synechial closure. But once there is a patent PI, I think the principles of angle closure are much the same as open angle glaucoma. So we would start with prostaglandins anyway.
Thank you so much. Thanks a lot, Dr. Vinay Nangia. That was a wonderful case which you showed. You stay on with us, and we shall go on to our next speaker, Dr. Sati Devi, who's a consultant glaucoma services at Narayan Netralaya, Bangalore, with a long experience. And she's going to talk on a very interesting topic, shallow anterior chamber post-trabeculectomy. On to you, Dr. Sati Devi. Are you there?
Yeah.
Just share the screen.
Yeah.
Yeah, a very good evening. So I'll be talking today about shallow anterior chamber post-trabeculectomy. With glaucoma surgery, we are always looking at doing the balancing act between overfiltration and underfiltration. Shallow anterior chamber is one of the most common complications that we encounter in the postoperative period, and this can be associated either with a low intraocular pressure or with a high intraocular pressure. The two most common scenarios that we often see are wound leak and the overfiltration. High intraocular pressure is a little uncommon. I'll try to cover two case examples of this scenario. So this was a 64-year-old patient who had primary angle closure glaucoma and underwent a Phonics-based trabeculectomy with mitomycin C. And on the 5th postoperative day, the patient presented with this shallow anterior chamber. So both in the periphery as well as centrally, you can see that there's a shallow chamber. The intraocular pressure was 2 millimeters of mercury. And on examination of the bleb at the slit lamp, the bleb was found to be relatively flat. And you can see that there is a leak that is happening at the edge of the conjunctiva. Patient was also noted to have peripheral choroidals. Now, how could we prevent this? We would need to, during the surgery, avoid the mitomycin coming in contact with the edges of the conjunctival flap. Gentle handling of the conjunctiva intraoperatively to avoid buttonholes is very important. At the end of surgery, it's important to ensure watertight closure on the table itself. So this is truly a situation where a stitch-in time saves 9. So if you do notice a leak on table, it's better to take care of it there. So here in the first figure, you can see that this is a limbus-based flap. And in this situation, you can do two-layer suturing, the tenons and conjunctiva. So it gives a really watertight closure. And generally, the leaks in this situation is extremely low. This here, the third picture here shows a Phonics space flap. And so you're suturing at the limbus. I'm using a frill of conjunctiva and closing it conjunctiva to conjunctiva. Again, with careful suturing, you can get a watertight closure. Now that we already have a leak, what do we do next? A bandage contact lens is extremely useful in this situation. It covers the area of the leak and facilitates epithelial migration. So here you can just see the lens being inserted. The edge of the lens seen here should well cover the area of the leak. So if you have the edge rubbing against the leak, then that could prevent closure of the leak. So that one needs to be careful about. You reduce topical steroids so that there is some amount of inflammation and you want the leak to heal. You can give cycloplegics, which will help in posterior movement of the lens and formation of the chamber. And you can also give drops like gentamicin, which cause some amount of conjunctival inflammation and stimulate wound healing. Oral doxycycline is also useful. Now, by day 17, with all these measures, the leak had sealed, the anterior chamber had formed, and the intraocular pressure had come back to 12 millimeters of mercury. Now, when would a surgical intervention be required in such a situation? Usually very uncommon. Most of these respond to conservative management. But if you see that there's an imminent risk of blood failure, if the blood is getting scarred, you see a brisk leak which is persistent, and this places the eye at high risk of infection, then you would want to go in and close the leak. Also, if the shallow chamber persists for very long, there is a risk of peripheral anterior chamber, PAS, peripheral anterior synechia formation. And sometimes if the shallow chamber remains for long, even though not at that time, later when the patient undergoes a cataract surgery, the cornea could decompensate, hypotonous maculopathy can happen, persistent ocular pain, all this could be indications for surgical intervention. Emergency situation that you would need to intervene is if you see kissing choroidals or a lens cornea touch. This is a second case, which is a 72-year-old male, primary open angle glaucoma who underwent trabeculectomy. Again, on day 5, you see that the chamber was shallow, pressures were 3, and he had peripheral choroidals. However, this case differed in the fact that there was a very large bleb and there was no leak that was seen. Now, this differentiation is very critical because the management is totally different. So here, to prevent this, you on the table, make sure that the AC is formed well intraoperatively, adequate thickness of the flap, the covering of the stoma by the flap. So central 1/3 alone, you have the stoma. Use adequate scleral flap sutures, use releasables, avoid flap tears or disinsertion. Check the filtration after your suturing, instill a cycloplegic at the end of surgery. Management, you can give a pressure bandage. Usually I give it during the waking hours to avoid during Bell's phenomena. You don't want the pressure bandage on the cornea. Increase topical steroids, put atropine. And with this, the patient by 8th postoperative day, AC was much better. And by 14th day, it was well formed. Pressures were 10 and choroidals were regressing. Again, these also majority settle down with conservative management. Very few require surgery. If the chamber does not follow, then a wound revision with resuturing of the flap may be required. If the flap is badly damaged, then you may have to consider a scleral patch.
Ma'am, 1 minute remaining.
The situation of high intraocular pressure in shallow chamber is, like I said, quite rare. Pupillary block, which can happen either due to imperforate PI, block by blood, fibrin or vitreous. You need to relieve the block. Malignant glaucoma, again rare, more common in angle closure eyes. Medical management, laser hyaloidotomy or iridozonular hyaloidotomy may be required. Suprachoroidal hemorrhage is a devastating complication. It may still be possible to salvage with appropriate intervention. It's quite common in myopic eyes, aphakic, post-vitrectomized eyes. In this, you would need to use an AC maintainer, avoid sudden decompression or hypotony. So I would like to conclude by saying that postoperative complications are fairly common post-trabeculectomy. They're mostly transient and respond quite well to conservative management. Recognition of the condition, assessing the etiology, and appropriate management help in preserving vision and bleb function. Thank you.
Thank you very much for throwing light, so much light on a very important aspect of our trabeculectomy surgery. I would have a question for Dr. Vijaya. How would you actually differentiate overfiltration from aqueous hyposecretion?
Overfiltration with the aqueous hyposecretion. Overfiltration, usually we notice in the immediate postoperative period, mainly because of the closure is inadequate. And when there is overfiltration, there will not be any leak from the edge, and there will be very large blood functioning and associated with the hypotony and hypotony related sequelae. When there is aqueous suppression, there is no production of the aqueous. I don't expect a well-formed bleb in such a situation.
Or bleb will not be well formed, and maybe if there is some
And
inflammation.
you have to rule out a possible leak. So doing the sedals, even if there is a leak, you will not have a well-formed bleb.
Yeah. Or if there's some cyclitis or inflammation, probably too, you could have had.
Unlikely you see that often such a problem in the immediate post-trabeculectomy. So those conditions you see in the long run rather than in the immediate post-operative period.
Many times we have seen, ma'am, like when you talk about sedals, during the normal sedals, there won't be any leak. But in some cases where the pressure sedal is slightly, there will be a leak. Many times we won't find it. And we constantly have this bleb being flat. But one normal sedals, it will be negative. But once you have a gentle pressure sedals, it will be positive. So many times we see that situation also. I don't know how many of you have faced that.
So
I think a forced.
Sorry, go ahead, Satya.
Pressure sedals, just gentle pressure, you can see that there is a leak.
Yeah, so forced sedals can be seen often, but that is even easier for it to settle with the same conservative management, because most of the time without the pressure, there is actually no very active leak.
Yes. I don't know who interrupted this. How would you manage conjunctival leaks, the intraoperatively in Phonics-based incisions, Dr. Tanuj?
I think that is the most critical question you have asked. And I have also had several leaks, and still I'm refining my closure. So the first thing I do is now on the table when the surgery is ending. So I have closed the Phonics-based flap. So I ask my assistant to pour trypan blue on the site of closure, and I inject balanced salt solution from the side port. So when the second option is that when you have done the surgery, you are giving the subconjunctival injection that will balloon the conjunctiva. At the same time, you can put trypan blue. So if there's any area where there is leakage, you will see that trypan blue getting diluted. So I think that is an acid test that before closure, you balloon the conjunctiva with either of these two maneuvers and check for leakage on the table. If you find an area where there is dilution of the trypan blue, you immediately suture it on the table. Second principle is don't rely on absorbable sutures, vicryl. So I have burnt my hands. Vicryl, you are never sure of the integrity. So the apposition of the conjunctiva to the cornea, you may use one or two vicryl sutures to hitch the conjunctiva, but the central closure must be done with a watertight 10 or monofilament nylon suture. That is a must. And third modification recently I have started doing is because you can get a lot of astigmatism when you apply 10 suturing to the periphery of the cornea. So I leave a frill of conjunctiva, and then we are just trying for the last maybe 3 months to use 10O vicryl. So that's a very fine suture, and the space between two bites is very minimum. So we go two ways, and that has given in the initial study we are doing good results, but I'll wait and maybe 6 months later I'll tell you that. So these are three different techniques you can use. And if you find post-operative there is a micro leak, then of course you can manage it. But if there is a gap between two sutures in a Phonics-based flap, then better to take the patient to the OR and suture it, because you are exposing the patient to a risk of blebitis, and then it becomes a very difficult situation. So micro leaks you can manage conservatively, but if there's macro leak between two suture lines, then you should seal it in the operation theater. Thank you.
And of course, very atraumatic handling of the conjunctiva, and I suppose including tenons in your suture.
Yes.
Should be it. So any other question from the expert panel on this talk before
comment on this? Actually, you should also aim for a posterior flow of aqueous, because if the aqueous flows posteriorly, then the approximation of the conjunctiva to the at the limbus is better. And Dr. Tanuj has suggested not to use Vicryl, but I have been using Vicryl for so many years, and I now give purse string sutures on the sides. And the advantage of having purse string sutures is that the tension of the suture is at the limbus. So the chances of retraction of the conjunctival flap is also minimal. And in the center, two bleb forming sutures, it can be given either with nylon or with Tenno Vicryl. So yeah, the aim is to have a very good watertight closure of the conjunctival wound and aim for a posterior egress of the aqueous rather than having the egress of aqueous from the sides, which can prevent healing of the conjunctival flap.
Thank you. Thanks a lot for these wonderful inputs. We shall now go on to our next speaker, Dr. Tanuj, who is going to be talking on delayed hypotony after trabeculectomy. Again, a very important topic.
Thank you, Dr. Chitra. So in 5 minutes, I'll be giving a pre-recorded talk. And this is a brilliant resident from RP Center who has helped me, and his voiceover. So telling you 3 situations about how to manage hypotony maculopathy.
Bleb revision techniques for managing hypotony maculopathy. We have no financial disclosure. Trabeculectomy is one of the most widely performed surgery for managing glaucoma. This video demonstrates a series of 3 surgical techniques for managing overfiltering or leaking blebs causing hypotony maculopathy post-trabeculectomy. Transconjunctival compression sutures for overfiltering bleb. A 40-year-old lady with a history of right-operated trabeculectomy 1 year back presented with complaint of diminution of vision in her right eye for 1 month. On examination, she had right eye hypotony maculopathy with an intraocular pressure of 3 millimeters of mercury. She had a mildly elevated diffuse vascular bleb with no leak. AIOS OCT showed multiple subconjunctival fluid pockets and a wide intrascleral route causing excessive aqueous drainage. A 10-0 monofilament nylon suture was passed transconjunctivally from the limbus to posteriorly beyond the filtering area of the bleb. The plane of the suture is confirmed by presence of resistance felt against the needle while passing through the sclera. Multiple parallel compression sutures are utilized to cover the bleb area. Post-operative AIOS OCT showed reduction in the size of the intrascleral route, and an intraocular pressure of 16 millimeters of mercury was achieved by the end of 1 month with resolution of hypotony maculopathy. Avascular bleb revision using conjunctival advancement. This video demonstrates management of a patient who presented to us with a thin cystic avascular bleb and hypotony maculopathy 2 years after trabeculectomy surgery with mitomycin C. The conjunctiva over the thin avascular bleb was stained using trypan blue dye, and the epithelium is scraped off using a percent blade. The thin necrotic conjunctiva is removed, and the surrounding conjunctiva is undermined to create a Phonics-based conjunctival tenon flap behind the avascular bleb. The conjunctiva was advanced to cover the trabeculectomy site using 8-0 Vicryl sutures at the 2 edges. And additional 10-0 monofilament nylon mattress sutures were put circumferentially to anchor the flap at the limbus. Post-operative clinical picture and anterior segment OCT showed a well-formed bleb at the end of first week. Management of hypotony maculopathy post-trabeculectomy with scleral patch graft and conjunctival overlay. This video demonstrates a surgical technique in a patient who developed hypotony maculopathy 4 years after trabeculectomy surgery. The patient's intraocular pressure was 4 millimeters of mercury, and he was found to have a thin cystic bleb with sweating and associated hypotony maculopathy. After local debridement of the unhealthy conjunctiva over the bleb, the surrounding conjunctiva was undermined to create a Phonics-based conjunctival tenon flap. Intraoperatively, the scleral flap was found to be thin and necrotic. A 10-0 nylon suture was used to close the existing flap, but due to tissue friability, the suture cheese-wired. After removing the necrosed scleral tissue, a partial thickness scleral allograft was fashioned and sutured at the trabeculectomy site using 6-0 vicryl sutures at the 4 apices. Additional 10-0 nylon suture was used to fix the donor sclera anteriorly at the limbus. The conjunctival tenon flap was then advanced over the scleral patch graft. Post-operatively, patient had good IOP control with resolution of hypotony maculopathy. Overfiltering and leaky blebs are a known complication of trabeculectomy surgery, especially with the use of antimetabolites. Each case needs to be evaluated individually, and the best suited surgical technique should be selected for its management. Thank you.
Thank you very much. Thank you very much, Dr. Tanuj. It gave us entire gamut of management. Would you think that your trap could still fail after an epithelial exchange bleb repair?
So I think that is definitely a risk. So first thing is there is no option because you have hypotony maculopathy and you have to do a site-saving procedure. So you have to replace it with healthy conjunctiva. These eyes are also at risk to go into blebitis and endophthalmitis. So when you replace it with a healthy conjunctiva and you advance the flap, definitely there is a risk that the function of the trabeculectomy will go down, and you need to follow up these patients over long term, and many of them require medical therapy to control the intraocular pressure. So definitely there is a downside to this, but there is no option in these cases.
Dr. Shailesh, would you have a question?
Yes, sir. Hypotony maculopathy, how many days do you wait? Because it can cause irreversible blindness also. I mean, what is the masterly inactivity period to prevent irreversible loss?
So I think, Shailesh, most of these patients come in the late post-operative period. So maybe many years after surgery, many months or years. That time, there is no role of conservative therapy, especially when you find that the conjunctiva is thin and due to mitomycin toxicity, the conjunctival barrier is compromised. So there is no point waiting. It is best to go ahead and change the overlay with the healthy conjunctiva, because you are leaving these patients at risk for infections, and they can lose sight. So I don't think there is a role of conservative wait and watch policy if you have a late hypotony with maculopathy.
So looking into these things like delayed hypotony, do you refine your surgeries like concentration of mitomycin C or adding on Ologen to avoid such complications?
So first issue is avoiding complication. So long time back, we have switched from limbus-based flaps to Phonics-based flap. That reduces the complications related to the bleb. The second is the wide posterior application of mitomycin C. That is a must. And if there is no risk factor, then we use 0.2 milligram per ml for 2 to 3 minutes. If patient has a risk factor for failure of a previous surgery, then we go ahead with 0.4 milligram per ml. And Ologen, we have tried extensively. There is no role of Ologen. It doesn't help. It just adds to the cost of surgery. And we did not find it enhanced success in any way. And it's not at all a replacement to mitomycin C. So we are not using any wrong.
Okay, thank you.
How would ASOCT help you in planning your surgery in a delayed hypotony?
So that is very good question. ASOCT is helpful because to make the decision of having a scleral patch ready or just doing a conjunctival overlay. So on the ASOCT, if you find that there is a defect in the sclera or there is evidence of scleral necrosis, then you have to arrange for an eye bank sclera. And if in case because of the COVID epidemic, the eye bank sclera is not available, then you can do what is known as a Momini's repair. So you can raise a scleral flap from the adjacent sclera and rotated and covered the area of the scleral defect. So that is another technique. Maybe I'll show it in some other webinar next time.
Thank you so much. Thanks a lot for your inputs. We shall now go on to our next speaker, Dr. Parul, who's a professor at the Department of Ophthalmology, PGI, and she's going to talk on a very important topic, glaucoma management in a patient with pseudo-exfoliation. On to you, Dr. Parul.
Good evening. Good evening, everybody. I work at the Government Medical College, Chandigarh, and I would be speaking upon glaucoma management in patients with the pseudo-exfoliation. So we have this patient, a 67-year-old gentleman from Himachal Pradesh, who complained of decreased vision in the left eye since a year. He didn't have any relevant medical history. The family history was non-contributory, and there was no history of use of steroids or any past trauma. The best corrected visual acuity in the right eye was 20/20, and it was 5/60 in the left eye. There was an RAPD in the left eye. The pressures in the right eye of any medications were 19, and they were 29 in the left eye. The pressures increased after dilatation to 34 millimeters of the mercury in left eye. In the right eye, they were about 20 or 21. The optic nerve head showed about 0.4 vertical cup disc ratio in the right and a significant 0.9 cupping with bipolar notching in the left eye. The slit lamp examination revealed nuclear sclerosis, which was early in the right eye, and about 2 to 3 plus nuclear sclerosis in the left eye. On dilated lens surface, we could see the typical bull's eye pattern, and there was also some amount of scruffy deposit on the pupillary rough, although there was no peripapillary transillumination defects. The gonioscopy of both eyes showed open angles, and in the left eye, we could see a very prominent sample Eces line, as is very evident here. Pachymetry was towards the thicker side. The diurnal variation of intraocular pressures showed a significant amount of fluctuation in the left eye, with the highest pressure in early morning being about 35 and the minimum in the left eye being about 27. The perimetry in the right eye showed just a few defects, and the left eye showed significant defects, and there was a split fixation when a 10-2 test was done, which corroborated with the disc. The salient features of this case were that the patient was over 60 years old, was from a hilly terrain, had scruffy deposits at pupillary rough, and a classic target pattern on the anterior lens surface, a prominent sample Eces line, asymmetric cupping, significant diurnal variation, an increase in intraocular pressure on dilatation, and all this pointed towards the diagnosis of pseudo-exfoliation glaucoma. The patient was started in both eyes on bimatoprost. A week after starting the treatment, the pressures were 14 in the right and 24 in the left. Another drug was added in the left eye, and that was timolol. A week after addition of timolol, the pressures were 18. The patient was given an option of getting a combined phaco with trabeculectomy done. The patient somehow did not want trabeculectomy either as a standalone procedure or as a combined procedure. So we went ahead and did a phaco surgery for this patient. Preoperatively, what is important to assess in a case of pseudo-exfoliation is to look for zonular dialysis, phacogenesis, any asymmetric anterior chamber depth, and the corneal endothelium. And all these were missing. The corneal endothelial cent count was good. So we went ahead and did a phaco. It's a good idea to use a small incision size in these cases. So I used a 2.2 millimeter incision, did a large CCC, prolapsed the nuclear fragment in anterior chamber because I wanted to avoid zonular stress. In cases with pseudo-exfoliation, chopping is a preferable technique. And as a safe option, I had taken a 3-piece IOL in case there was any complication on table. And acetazolamide should be given to these patients to prevent any postoperative IOP spike. Now, why should we bother learning about pseudo-exfoliation management since it's an open angle sort of glaucoma? Well, isn't the management going to be pretty much similar to a primary open angle glaucoma? Now, angles may not always be open, and a lot of studies have shown that narrow angle pseudo exfoliation is quite common in Asians, which could probably be because of the zonular weakness, which causes anterior lens displacement, and hyperopia sort of adds to it. These patients tend to have an aggressive course. The rate of conversion of patients who have just high pressures to developing a full-fledged pseudo-exfoliation glaucoma is quite high, to the tune of 40 to 50%. And the surgical complication rate is also quite more in patients with pseudo-exfoliation. Additionally, when complications occur, these patients are a little bit more resistant to steroids as compared to primary open-angle glaucoma patients. So some practical pearls when it comes to medical management of cases with pseudo-exfoliation glaucoma. We must remember the 24-hour IOP characteristics, and there are high IOP fluctuations in these cases. So one must aim to dampen the IOP fluctuation to 3 millimeters or less. Sometimes you may need to do a diurnal variation of IOP even on medications, and if you find that the IOP fluctuations are more than 3, then you need to address and revise your treatment. Therapy with multiple medications is needed, and sometimes adjunctive SLT needs to be done for these cases. The threshold for any form of surgical intervention should be relatively earlier in these patients, and medical therapy for patients who have secondary angle closure due to pseudoexfoliation is different from cases with primary angle closure, because here we don't want to give myotics. They will make it worse. Since the pathology is because of zonular atropine is something that needs for these cases. When we talk about intraoperative issues, if we talk about cataract surgery for these patients have poorly dilated pupils. So we either need to use, we need to lyse synechia with blunt spatula, or do stretch pupilloplasty, or use highly viscous OVDs. For zonular fragility, you need to keep a CTR ready in case there is any problem on table. And what else we can do? That surgery needs to be done in early stages of the disease to avoid harder nuclei. You need to avoid excessive fluctuations in the anterior chamber pressure through the use of small incision and adequate viscoelastics. Tap the center of nuclei from time to time during hydrodissection to decompress the fluid and fluid pressure on the posterior capsule. And if you have a cannula which has 2 side ports from which you can do a gonial wash, then that is something that can be done at the end of a cataract surgery. So thank you very much for your kind attention.
That was a wonderful talk. You know, I had tried to think of all the questions to ask you, but you really covered it all.
Yeah.
The association of an angle closure disease and pseudo-exfoliation you've covered, and also the unique issues which have to be addressed when you're doing a pseudo-exfoliative case. So I'm going to try to ask any of the experts panel, Dr. Sunita Dubey, maybe, would you think that GAT is a better option in these eyes with pseudo-exfoliation, or at what stage?
GAT. Okay. Actually, pseudo-exfoliation, as she has mentioned, you need to, because these patients are very fast progressors.
Yes.
And the chances of progression is pretty fast, and you over a period of time, the angle also becomes narrow. As the zonular weakness increases, there is progressive shallowing of the chamber and narrowing of the angle. So in the later stages, you may not see the angle structure so well. So I don't think that in the later stages, when the cataract,
no, not later stages, early stages of pseudo-exfoliative glaucoma, would anybody consider doing a GAT?
Yeah, actually, I have the experience of trabectome. Trabectome works very well when there is pigment deposition or pseudo-exfoliative material in the trabecular meshwork, which causes damage to the trabecular meshwork. So I think those procedures can be used initially when the glaucoma is not so advanced and there is progressive damage to the trabecular meshwork because of the deposition of these pseudo-exfoliative material. And still, when the collector channels are open, the disease has not advanced up to the collector channels.
Yes.
In the initial early stages of moderate glaucomas, they can be considered. But when the cataract, when the glaucoma has progressed to the extent that it has extended up to the collector channels and the lens may be subluxated, there can be zonular weakness, then I think maybe with all precautions what Dr. Parul has mentioned, I think that should be kept in mind, and a combined surgery like Phaco-Tract can be done, because these cases can progress very fast.
Dr. Sunita, would you have, I'm sorry, Dr. Shushmita, do you have anything to add here?
So, I mean, if I was doing just a cataract surgery and not contemplating a trabeculectomy, I might think of adding a GAT, which make sense. But if the patient has a glaucoma which would require a glaucoma surgery, I would not keep GAT as my, I would do a trab or a Phaco-Trab. So depending on whether glaucoma surgery is required, that would, but yes, it would add to a Phaco. So definitely in that case, I would consider a angle surgery along with.
Dr. Vijaya, can you tell us what would be the guideline in following up the fellow eyes if they do not have glaucoma?
Actually, pseudo exfoliation per se is to start with, it starts as unilateral. So with the time, only the other eye will develop. It's not uncommon. You see one eye pseudo exfoliation, other eye normal. But people say that if you do the conjunctival biopsy, you still will see the evidence of pseudo exfoliation. So you have to follow them up because you can't control it. At present point of time, we don't have any drugs that can address the deposits of the pseudo exfoliation. We are hopeful with the time. I'm sure that there is so much work is happening in the basic science. We may have some kind of a therapy that can reduce the deposit. Coming to the management of glaucoma, they are very aggressive glaucomas, unlike open angles and angle closures. They progress very fast. Blindness rates are much higher. I think whatever you do, it has to be a procedure that will control the pressure very well. I think we cannot take pseudo exfoliation lightly and try to play with it. As like Sushmita said, there is no cataract. I mean, there is no glaucoma. Just doing the cataract will take away a lot of material. Simple phacomulsification itself will drain a lot of material because you use so much of vacuum. So it takes time for the material to get deposited again. So that even just doing a cataract without doing any further is a good option.
Thank you very much. We shall now go on.
I have a question from Sushmita, ma'am.
Yes.
The moment I explained the risk of a possible wipeout, since the patient had split fixation, so he was a little reluctant to get any form of glaucoma intervention done. Ma'am, I had kept SLT as a stopgap in my mind, that if the pressures start to rise after cataract surgery, I would consider that. Do you think that would be a valid option and would work well for this patient?
I'm not sure, because if there is glaucoma, which requires control, I would try to counsel the patient for a trabeculectomy, because they really, as Dr. Vijaya said, they progress so fast, and we wouldn't have the time to experiment with whether or not the SLT would work with the pigmentation there. So I'm not sure I would offer that. I'd offer a surgery, a definitive surgery, if it's uncontrolled.
Parul, just a small suggestion. If you tell patients the wipeout, you make it very clear to them. If you take a chance, there is a possibility you will maintain the vision. Yes, there is a small risk of wipeout. If you don't take a chance, the chance of you become blind with the time, maybe in the next 5 years in pseudo exfoliation glaucomas, is 100%. So that will tilt the choice towards the surgery. I think, I'm sure
you remember that. Yes.
Thank you, Parul, and thanks expert panel for wonderful inputs. We shall now go on to our next speaker, Dr. Vanita Patak, who is currently a director of glaucoma and cataract at Director Glaucoma and Cataract at the Center for Sight Group of Hospitals based at Hyderabad. And she is going to take us on to a very interesting, much discussed topic, GAT, and let's hear from her.
Thank you very much, Dr. Chitra, and a very good evening to all of you. Did you notice that several talks preceding mine and several talks after mine will all are all concentrating on complications and side effects of trabeculectomy. And therefore, possibly MIGS or minimally invasive glaucoma surgeries may have a role to play earlier on in the disease, always remembering that in our country, presentation may be late, and of course, affordability may be low. Nonetheless, I have no disclosures here. There will be a talk about this, but infection, phlebitis, this patient did well, very fortunately, but it's a blinding disease. We all know that, bleb associated. But these, that may not be that common. However, TRABs and blebs like this are pretty common earlier on in the post-trabeculectomy, and later on post-trabeculectomy, you can have a variety of blebs. So the trabeculectomy as well as glaucoma drainage devices may be the mainstay, but the problem is that they are all subconjunctival. And a subconjunctival bleb that is formed is what unfortunately limits the function of that filtration. However successful it is in, or efficacious it is in bringing down pressure. So the bleb that is created is prone to fibrosis. So failure rate is high. And as a rough guidance, I've given you 50% at 5 years. And of course, there may be infection. And so the search for an ideal or a procedure with minimal side effects, minimal learning curve, repetitive results, etc., goes on. I'm not saying GAT is, has a low learning curve, but, So what is MIGS? Over the past 2 decades, MIGS has provided lots more options in the management, especially in mild to moderate, in the spectrum of disease much early on, and is usually blebless when you compare it with conventional surgery, and is usually ab internal. So you utilize either the trabecular meshwork or the suprachoroidal space or the ciliary body to provide or deliver your MIGS procedure. Based on this, the broad classification is that it could be trabecular meshwork or canal based, which you can either stent or dilate, or you can do an otomy, a trabeculotomy, or you could place it in the suprachoroidal space, as I just showed you, or you could do a cyclophotocoagulation. There is also a group of minimally invasive, which are known as MIGS plus, because they form a bleb, and you may or may not be using mitomycin C in those scenarios. In our country, very recently, iStent has been made available, and the procedures that are done and have been being practiced are, for the last few years, I would say, is the trabeculotomy procedures. For all these procedures, they are possible only when the angle is open, whereas cyclophotocoagulation is not dependent on angle status. What is the advantage of MIGS procedures versus bleb forming surgery is that it reduces surgical time, complications, can be offered much earlier on in the disease, usually combined with cataract surgery, and it's cosmetically more acceptable, visual recovery much faster. And from our point of view, a glaucoma specialist point of view, it does not compromise the conjunctiva at all. Of course, there's a flip side. There is only a modest reduction in IOP, and therefore, when very advanced disease, its use may be limited and usually not indicated in angle closure, and it opens up post LPI, and cost may also be a limiting factor. With this background knowledge, let's move on to my case. Here, there is a 17-year-old male. He had a history of use of unsupervised steroids and was currently on 3 anti-glaucoma medications in the right eye only. On examination, his best corrected visual acuity was 636 in the right. It was normal in the left. Intraocular pressure was 21 in the right, 16 in the left. Angles were open, and there was mild inferior thinning and RNFL change in the right eye, and a mean deviation about -10 in the right eye. Left eye was within normal limits. So here we had a situation of steroid-induced glaucoma and cataract with vision that was compromised due to posterior subcapsular cataract. And on anti-glaucoma medications, 3 anti-glaucoma medications. So what I decided to do with this patient was to, well, actually it was lens aspiration, not phaco, but with intraocular lens and a 360-degree suture trabeculotomy under topical anesthesia. And I will take you through this procedure, but just as a background knowledge about the tips for performing a successful mix, all kinds of mix, is that preoperatively you have to counsel expectations. And if the patient is on antiplatelet drugs, of course not this one, but older patients, then you must stop it. And you must actually undergo pre-planned, pre-procedure practice of intraoperative gonioscopy in phaco alone cases. And you must be aware of different types of intraoperative gonio lenses. You must practice this under high magnification and use a Sinski to the trabecular meshwork just to get a feel. So the types of intraoperative gonio lenses, these are of course direct lenses, and the most common one that was being used was Schwann-Jacob. And the view you get with it when you compare it to the newer lenses, I feel is a little less ideal. Something which is very similar to Schwann-Jacob is an open axis, eye prism open axis. As you can see, the design, there is a little concave cutting in the front. The advantage of these 2 lenses are that they can be reused. However, when you look at the other lenses that are available, this one is an eye prism. You can see that the view, the appearance of the trabecular meshwork is much better. Here I'm placing an eye stent in a patient. This is an eye prism SX, and this gives a much wider view, en face view of the angle structures. These are unfortunately a little bit more expensive, and they are disposable, although I do ETO them and use them for 4-5 cases. The other most important thing is the positioning of the patient and the microscope, and the surgeon should be sitting temporal. Microscope positioning should be 35 degrees, so the patient also should be positioned 35 degrees. In this fashion, you can move the microscope towards yourself and the patient's face away from you. So here we are, move the microscope towards you, patient's face away from you. Then you create corneal wounds which are slightly anterior to the limbus so that you can avoid bleeding and poor visualization. You can see here the little space that I have left for making the phaco wound for this particular patient, and practice intraoperative gonioscopy in phaco cases, like I said, under high magnification and Sinski to the angle. As you can see here, this is just a Sinski hook, and this is an angle closure patient whose angle opened up, and you can see small gonius iniki also formed. But it just gives you an idea as to how. So here, with this patient, the procedure was completed without any complications. An initial goniotomy was done, followed by 5-0 proline cannulation of the entire Schlemm's canal, unroofing of the Schlemm's canal, 360 degrees. And at the time when I was performing GAT, unfortunately, my microscope was not very good. So I managed to get a very good video from a very good friend of mine, Dr. Swati Upadhyay, from Aravind, Pondicherry. So I'll just fast forward it. You can see the wounds being made, and you saw the tip of the proline being blunted. And once the patient is and the eye is positioned, you place the gonio on the eye and you do a goniotomy with an MVR blade. Once you've done a goniotomy, then you grasp with the micro grasper and you cannulate the suture into the canal till it appears on the other side, and you can grasp that with your micro graspers, and then use a McPherson's to just rip the trabecular meshwork 360 degrees. So with this particular patient, I had minimal inflammation and no hyphema. He achieved 20/20 vision as well as controlled pressure without medication of the 2.5 years follow-up I have. I just want to contrast it with another male patient, 10-year-old, who was a primary congenital glaucoma patient, who had already had a trab and trab elsewhere, was on medication, 3 medication, and he had poor fixation because his vision was very poor, count fingers 1 meter only, one-eyed patient, IOP was not controlled at all. And the factors that needed to be considered here, that he's one-eyed, previous failed not only bleb surgery, but also trabeculotomy, outstation patient, and known poor compliance, and of course, cost. So mix was done in the form of GATT. Here, the modification was the surgeon position was superior, goniotomy was done inferiorly. 180-degree cannulation was first done anti-clockwise, and it came out of the previous trabeculotomy. So this was pulled through, and similarly, the other side was done and pulled through. This patient had a few blood clots post-operatively, but did not allow any observations on day 1, did not appear for the week 1 appointment. And when he came at 1 month appointment, his vision was 1.5 meters, pressure was 17, 1 anti-glaucoma agent was added, but unfortunately since then also was lost to follow-up. So what complications can you expect? You can have iris endothelial lens touch. It of course decreases with experience. You may fail to cannulate 360 degrees, and hyphema can happen up to 70% of cases. And late post-operative period, you can get fibrosis and pus formation and a need for glaucoma filtration surgery as high as 20%. So to summarize, I would say it helps to bypass the trabecular resistance, mostly indicated in open angle, mild to moderate cases. It has the potential to be considered as the primary surgery in primary congenital glaucoma. Of course, there is extremely limited data in Indian eyes, and unlike some other eggs, the monetary cost is not a limiting factor. But since the last 2 years, I have been thinking repeatedly about this procedure and found words in an editorial by Dr. Tanuj Dada. Very strongly, I feel now that non-preservation of 360-degree of trabecular meshwork eliminates use of any other trabecular meshwork-based drugs or procedures. And so much research is being done on the trabecular meshwork such that any future development of trabecular meshwork-based drugs or procedures may be completely ruled out in patients who have undergone GATT. Thank you very much.
Thank you very much, Doctor, for giving us some food for thought, Dr. Vanita, at the end of it. And let's take the question directly to Dr. Tanuj. Now, what would you say about, since GATT is a procedure which has come in recently, what do you think is the future of GATT?
Why would you require it?
So, Madam, actually, I would request all of you to read their editorial. And, I had this philosophical insight, that why would Mother Nature place a trabecular meshwork in the eye if there was no use of trabecular meshwork? So it is there for the purpose. And if you see the molecular studies, it's not a sieve, it's an active pump mechanism available in the eye to push aqueous. Now the issue is, second important thing is that recently we started doing aqueous angiography, and we just published a study on aqueous angiography guided ab interno glaucoma surgery. And if you do aqueous angiography, you find that the venous outflow channels are very limited and mostly present in the inferior and nasal quadrant. There is no aqueous flow channel in the temporal quadrant. So it doesn't make sense to unnecessarily remove the trabecular meshwork in an area where there is no aqueous outflow channel. So I think doing 360-degree removal of the trabecular meshwork is not a good idea for the long term. And I explain why. Because the same effect you can get with a 90-degree or a maximum 180-degree removal of trabecular meshwork.
I agree.
So the IOP outcome is not different if you compare 180 versus 360. So first question is never remove 360. The second important issue is young patients. So suppose you have a 17-year-old patient and you have removed the trabecular meshwork, and supposing patient goes into physical training with sportsman or weightlifting. With Valsalva maneuver, there is a long-term risk of hyphema because now trabecular meshwork is out. So anytime the episcleral venous pressure goes high, you can get a delayed hyphema. And that is one of the complications that is being reported with GATT, spontaneous late hyphemas. And third thing, what Dr. Sushmita said, young patients, in 10 years, you have new drugs which are working on trabecular meshwork, and these patients will not have an option. And lastly, I think it is better to strip off the trabecular meshwork with a needle or a KDB or a trabectome. Why? Because you are leaving the two leaflets with GAT. So over time, these two leaflets can come back and fuse, and then you have a rebound increase in IOP. That is why I am not a great fan of GAT. I believe in ab internal surgery, but a limited opening of the trabecular meshwork to 90 degree, and that also with a 26 gauge needle. So there is no added cost. And this is only for early glaucoma, and a very limited reduction in intraocular pressure is to be expected. Thank you.
Thank you, Dr. Tanuj. But still, for people who are doing GAT in the audience, one question I have for Dr. Sushmita. How would you manage a suture obstruction in the Schlemm's canal? What are the different ways you would think of addressing it?
So whenever there is an obstruction, the main thing is do not keep going, because usually we are doing GAT with a Prolene, which is essentially blind. So we stop the procedure, use a sterile indirect gonio lens, do the gonioscopy and see where it is. So we've had these ends of the Prolene come out through the iris. We've had some of them even go behind the ciliary body. So it's not such an innocuous procedure. And I would request people not to keep pushing it if there is an obstruction. The best thing to do is try and strip off as much as you can from one side and re-enter from the other side if you want to really complete the procedure, rather than keep pushing on the one end.
Would you think of cutting down at that area which could have got fibrosed and then going further in the same direction?
No, I've never done that. Maybe I'm a lazy surgeon, but I think it would, add to the time of surgery so much. I would just rather strip off, and it's easy to do that with your max grip forceps. Strip off half of it, go in again from the other side, make another side poke, go in again from the other side, and do as much as you can. But like Tanuj said, it's okay if you can't. You can always do a bang or a goniotomy of the rest of the section. You can do a bang of the rest of the angle if you really wanted to treat the rest. So you don't have to, but don't force your way through.
While we are talking on bang or maybe KDB, Dr. Rashmi is there as one of the speakers. What would be your thoughts on the current status?
Yeah,
honest opinion.
Thanks, Dr. Chitra. KDB we've used in 15 eyes, and we've published the results also. So definitely, like Dr. Tanuj told, just one quadrant or two quadrants of opening the Schlemm's canal itself decreases the pressure. But definitely in our study, we did not use KDB in eyes which are high pressure. So patients who are on 3 or 4 medication and they had cataract. So in those eyes, we had done KDB, and now they're on only 1 medication. In fact, that 1 medication also we were using because the patients had advanced glaucoma and the pressures were 16 to 18. So just for the fear that it should not go up, we continued on 1 medication. But definitely KDB or like bang itself works well. 360-degree goniotomy may not be required in all patients. So in where the suture gets obstructed in between, if we just rip off at the place where it is getting obstructed and not trying to cannulate further and causing trauma to the adjacent structures, itself is beneficial. So I think just in 1 quadrant, whatever view is available of that gonio lens, if that much of trabecular meshwork is opened, also the IOP reduction happens, and definitely the number of AGM reduction will happen.
Can I just add, sorry, can I just add that KDB actually is not available in India. We should not get that idea. It is not approved by DGCI. Kahook dual blade. These are only procured ad hoc. And of course adds to the cost of surgery. So now wherever a trabeculotomy is what I am planning for a patient, and I like to do a bang trabeculotomy. As we said, we are not adding to the cost. We are well versed with the positioning of the patient, positioning of the microscope as well as with intraoperative gonioscopy. So actually BANG is working extremely well. Not that I have published, but I will publish soon. And in patients where I feel there is affordability, I would actually preserve the trabecular meshwork even more, and I would do iStent or iStent inject. In fact, I have 4 cases coming up tomorrow, but only in those patients where, of course, there is affordability. And to add to this, I will just say that at least here now, right now, it is completely covered by insurance, totally reimbursable by insurance.
Dr. Shailesh, I'm going to go on to the next speaker because we're running short of time. We have Dr. Vineet Ratra coming in as the next speaker, who's a senior consultant in cataract and glaucoma from Shankar Netralaya, Chennai. And he's going to be talking on a case discussing medical therapy in glaucoma. On to you, Dr. Vineet.
Yes, ma'am.
Are you sharing your screen?
Yeah, I'm just not able. Just 1 minute, madam. I was able to, but now I'm not.
Yeah.
Can you see my slides?
Yes, yes.
Yeah. So, well, thank you, madam, and thank you, AIOS. So, I'll be talking about medical management, and let's start with this patient, a 54-year-old gentleman who presented with blurring of vision in his left eye more since the last 3 months. He's a known patient of glaucoma since 14 months and was on prostaglandin analogs, a known diabetic who was allergic to sulfonamides. His best corrected visual acuity was 6.6 and 6. His extraocular movements were full. There was no RAPD. Slit lamp had no pseudo exfoliation, no pigments, and his intraocular pressures were 14 and 18 millimeters of mercury. His gonioscopy showed angle structures open till scleral spur. So what are the management strategies? You need to identify the type and mechanism of glaucoma, which in this case was open angle, and you need to identify those at risk of severe vision loss. So we need to ask certain histories. We need to ask for a family history of glaucoma, especially in siblings. It was negative for glaucoma. His father had retinal detachment. There was no history of steroid usage, sleep apnea, ocular trauma, smoking, no migraine, no history of any Raynaud's phenomenon. There was no history of him doing any yoga with headstands or any excessive water drinking in the morning. He only was a regular voluntary blood donor where he gave blood every 3 to 4 months and for so many years. So some guidelines, we need to establish a baseline IOP, if possible do 3 IOP readings at different times of the day. Always do a gonio, and if you're a postgraduate who's learning, you can always look at gonioscopy.org. Do a disc evaluation, take a stereoscopic disc photo, do a visual field, both a 24-2 or a 30-2 and a 10-2. Assess the structural loss, and to set the target intraocular pressure, you'll need to classify the glaucoma as mild, moderate, and severe. So we called our patient, and 3 days later he came, and we called him in the morning, and his intraocular pressure was 18 and 28 millimeters of mercury, and he had used his medications the night before. His pachymetry was 570 and 572, and this is what his disc look like. So in the right eye, there was a slight inferior thinning, which was more prominent in the left eye. And you can also see the retinal nerve fiber loss, which you can see more prominently in the red-green photo. So his fundus, his Humphrey visual field of the right eye was normal. And in the left eye, there was a superior defect, which was threatening fixation. The OCT did show thinning in both eyes, though within normal, there was some amount of thinning even in the right eye, both superior and inferior, and more thinning in the left eye, which can be seen even in this pie chart. The GCC again showed thinning inferiorly in the right eye and inferiorly and superiorly in the left eye. So we then need to classify the glaucomatous damage as mild, moderate, and severe, which helps us to determine the target intraocular pressure for the individual. So what is target intraocular pressure? Well, it's the upper limit or a range of IOP, which is judged to be compatible with the treatment goal, which will slow the rate of visual field deterioration to maintain the patient's quality of life. So if you have early glaucomatous damage with short life expectancy, high untreated intraocular pressures, and no additional risk factors with slow rate of progression, one can have higher target intraocular pressures, but one needs to reassess them time and again. So well, in our patient, we did set target intraocular pressures of high teens in the right eye and mid to low teens in the left eye. So which medications would one generally use as the first line, second line, or third line medication? Well, this depends on both the patient's characteristics and the drug properties. So it depends on both the systemic and ocular safety profile, the adherence and compliance of the patient, and whether he's willing to use it multiple times of the day, and also the efficacy of the drug as to what the target intraocular pressure is and what the cost of the medicine would be. One could use drugs that decrease aqueous humor production, drugs that increase aqueous humor outflow, or drugs which do both, and one could choose among any one of these which have different mechanisms of actions and different side effects. And this patient of ours was already on prostaglandin analogs, so then the target intraocular pressure was not reached. So what is our second option? So one option is to add a second drug or to consider laser trabeculoplasty. Well, if you're adding a second drug, do we switch or do we add? So well, if you were having a 15% fall in intraocular pressure with the first medication, then it makes sense to add a second drug. And if you're actually having to switch drugs, one needs to remember about the washout of the drugs. So most of our patients, or nearly 40% of the patients, require 2 or more medications to maintain sufficient reductions in IOP. And it's over here that combined agents are better because they provide better compliance since there's reduced exposure to preservatives and there's no possibility of washout effect of the second medicine. It's important to see that the patient is compliant or adherent. There can be various reasons why they do it. So one needs to communicate with the patients, ask them open-ended questions, always ask them how their vision is, especially as compared to their last visit. Ask them if they were using medications regularly. One could ask them if they forget medicine, did they do so in the last week? Are they having any problems with their current medications? Always simplify the regimen. I tell my patients to use, they all have mobile phones, tell them to set alarms on it or do them adjust their dosage along with daily routines like breakfast and dinner. One needs to take care of one major cause of compliance being poor is ocular surface. One needs to look at the eyelid margins, look at the fluorescein staining, both the corneal and the conjunctiva, and look at the tear breakup time. Preservatives, the BAK can affect the corneal epithelium and the conjunctiva. It can cause subconjunctival fibrosis with loss of goblet cells, which can negatively affect the long-term success rate of glaucoma filtration surgeries. So well, to get back to our original patient, we added Netrosudil in his left eye since we had a target which was mid to low teens. This is the Rho kinase inhibitor.
7 minutes remaining.
Yeah, on his last visit, his intraocular pressure was 15 millimeters of mercury with latanoprost in both eyes and a Netrosudil 7 p.m. in his left eye.
Thank you so much, Dr. Vineet. Thanks a lot. I have a question to Dr. Vinay Nangia in this. Are beta blockers always a no-no in all cases of in cardiac ailments, or is it specific to certain disease conditions? Dr. Vinay? He's not there.
I mean, if yes. You know, there is known bradycardia, or there's a previous history of cardiac block, or pacemakers being put in, you know, those are the times when you know, we would be a little bit hesitant with using beta blockers. But otherwise, you know, of course, asthma is one thing, and depression. These are other things that I would keep in mind if I were to use beta blockers.
And Dr. Vinay, when would you think of when a patient is already on systemic beta blockers in those patients?
Actually, there's been a lot of debate on this. I think the best thing is that if beta blocker is indicated, you always have an option of not using beta blockers because there are so many other medications. But if you are strongly inclined towards beta blockers, then please use beta blockers, see whether it has a pressure reducing efficacy, and then take a decision on whether it's all right to be using it actually.
Dr. Vinith, I'm going to ask you a question. What is the percentage of failures with the use of ROCK inhibitors? Question number 1. When would you consider removing these ROCK inhibitors a few days prior to TRAB surgery? And would you consider reusing it if the IOP is high in the immediate postoperative period? You need to answer.
The ROCK kinase inhibitors do cause congestion. There is congestion, there is hyperemia, but that's more because of the mechanism of action of the drug, that it causes vasodilation and does that. So cosmetically, if you tell the patient that yes, there is congestion, but there is a good fall in pressure, these are good drugs. They do reduce scarring, so I don't stop them preoperatively, and I would use them as my now in glaucoma patients, in patients whom have had cataract surgery, I do use ROCK kinase inhibitors as my first line drug, telling the patient that yes, your eye may look a little more red, don't get worried, but if it worsens, come back and show me. Post-operatively, they reduce scarring, so actually they would be good drugs to use in glaucoma surgery if your pressures are high post-operatively.
Oh, great. So that I think answered all my questions. Dr. Shailesh?
Yeah, and Dr. Vanita nicely covered, although it's a very vast topic to cover in a few short time.
Yes.
Like, when there are no contraindication, which will be your first line of therapy? Many times the questions are aimed at postgraduates also or the beginners. Second part is, do you think of monocular trial or you directly go ahead with the bilateral one?
Yeah, so that as of now, prostaglandins are my first line of drugs, especially if cost is not an issue. But now most of the drugs have come down with costs which are low, so prostaglandins do come up as my first choice. Sorry about the second question.
Monocular trial, like.
Oh, yes, definitely. So it again depends on the amount of damage. So if the damage is severe, if it's an advanced glaucoma with a lot of damage, then I wouldn't want to do a monoocular trial because I would want pressures in both eyes to come down. But if it is one which is mild to moderate, then yes, I would prefer to do a monoocular trial to see how much of fall in pressure is in the worst eye, and then decide on the other eye.
Thank you very much. Thank you very much. I think we are running really short of time. We go on to our next speaker, Dr. Pradeep Vyas, who's heads the Center for Sight at Indore, and his subspecialties are cataract and glaucoma, and a very experienced surgeon. And he's going to talk on a case with neovascular glaucoma. On to you, Dr. Pradeep.
Thank you, Dr. Chitra, and thank you, ARC, for this opportunity. Good evening, everyone. So I would be talking on the neovascular glaucoma. And we know that it is one of the most frequently encountered secondary glaucoma in our practice. And simultaneously, it is one of the most difficult secondary glaucoma to treat in our practice. So what is the mechanism for the neovascular glaucoma? It is basically because of the retinal ischemia, which causes the release of vascular endothelial growth factor. And there is an angiogenesis, that means that the formation of the new vessel over the iris and at the angle. And this leads to the formation of the peripheral anterior synechiae, and which leads to the elevation in the intraocular pressure. And there are several causes for the neovascular glaucoma. Diabetic retinopathy is the most important, followed by the central retinal vein or the branch retinal vein occlusion, and then retinal artery occlusion, ocular ischemic syndrome, uveitis, and ophthalmitis, and intraocular tumors are the other causes for the neovascular glaucoma. The treatment options available with us is the medical and surgical treatment. As I said, that it is one of the most difficult glaucoma to treat, and which I would be discussing with a case presentation. So in the management, we need a good glaucoma expert, we need a good retina expert, and we need a good physician as well to control this systemic condition. In the treatment, first we have to treat the ischemia because this is the cause for the development of the neovascular glaucoma. And then we have to treat the elevated intraocular pressure. And if the patient is symptomatic, then we have to treat the symptoms as well. So this is a 54-year-old gentleman presented to me with a complaint of perivision in the right eye. He was a known diabetic for last 21 years and was on insulin for last 8 years. And his diabetes was still fluctuating. He was given an intravitreal injection elsewhere, once in both the eyes. He was also having an essential hypertension, and which was fairly under control. His visual acuity in the right eye was 618 and in the left eye was 69. The intraocular pressure in the right eye was 32 and in the left eye was 22. In the anterior chamber in the right eye, there were neovascularization at the iris, and the conioscopy, there were NVS and the PAS. The fundus shows severe NPDR in both the eyes, along with the diabetic macular edema in the right eye. This picture shows that this patient has an NVI at the margin of the pupil. And he had a severe NPDR, you can see over here, along with the diabetic macular edema. And he has lots of new vessel at the angle and with the peripheral anterior synechias at some location. This was the optic now height picture, and he presented to me for the first time. And this is after some time when I started treating, and you can see that this is the perimetry. This was the first perimetry when he presented to me, and this is on the subsequent visit. And you can see that there was a significant diabetic macular edema in the right eye. On the FFA, there were significant area of capillary dropouts, which shows that the patient has a significant retinal ischemia. So for the treatment, I put this patient on a beta blocker, alpha-2 agonist and carbonic anhydrase inhibitor topically. And obviously the retinal reference was taken. And my retinal consultant has given him the anti-VEGF. There is, okay, anti-VEGF, and he did the extensive retinal ablation. And to control the intraocular pressure, I had to do the pathophysiology, and it subsequently failed. You can see over here. And this is the picture showing that how aggressively he did the retinal ablation in both the eyes. So, but in spite of the aggressive retinal ablation, this patient had a recurrent vitreous hemorrhage and a persistent high intraocular pressure. You can see that this picture is just for a depiction, and this is not the picture of the same patient, but this patient underwent pars plana vitrectomy and with the retinal photocoagulation again and in the leftover area. But still his pressure was pretty high. I did one trabeculectomy again, and the third surgery when I put the AGV in this patient, and then the patient has a normal intraocular pressure. This is another similar type of a patient which I had, and again in this patient also I did the true trabeculectomy, which failed, and then I put the seat on over here because to prevent the fibrosis. And you can see that okay, you can see that this patient has a significant, reasonably good bleb, and the intraocular pressure was well under control. So in spite of treating well this patient, you can see that at the last follow-up, this was this picture, and this patient had a just 560 vision and a very narrow visual field left. So in conclusion, if you have a patient of the neovascular glaucoma, you have to act very swiftly and very decisively so that the patient should not end up in this kind of situation. Thank you very much for your patience hearing.
Thanks a lot, Dr. Pradeep. Now I am going to have a question to Dr. Vinay Nandia. Is it possible for a neovascular glaucoma to clear up with PRP and anti-VEGF at any stage?
It is possible for neovascularization to regress with anti-VEGF and with laser. It's a little bit difficult to decide in which patient at what stage it's likely to regress. But if you have neovascularization of the iris and with neovascularization of the angle, but without significant degree of peripheral anterior synechia, then you may have expectations that could work actually. So I think that's what happened in Dr. Pradeep's case, that he did all the right things, but it was a kind of patient where, you know, it didn't really settle down and he had to go for the Ahmed glaucoma implant, actually.
I suppose if NVG is in an open angle kind of situation, we escape rather than it goes into a narrow angle status.
Yes,
Dr. Vijaya, can I ask you this question? Is there a role for trabeculectomy at all, or it's no?
It depends upon what stage it is. If somebody who had a open angle NVG that got regressed with anti-VEGF and the PRP, it doesn't mean that intraocular pressure will get normalized. If the trabecular meshwork has been affected, and it will leave behind a defective trabecular meshwork, so you will have raised pressures. In an eye which is quiet, which behaves like an open angle, there is no harm in doing a trabeculectomy in such a situation. If there is any doubt that new vessels are still active, we do give anti-VEGF a day or two before doing the trabeculectomy, allow the eye become to quieten, and then we do the trabeculectomy. So the tubes, we keep it mainly for advanced closed angle stages.
Thank you. Paucity of time, there's a lot to discuss here, but I'm going to move on to the next speaker, Dr. Venkatesh, who's the Chief Medical Officer of Glaucoma Services at Arvind Eye Care Systems, and he's going to talk on steroid-induced glaucoma. On to you, Doctor.
I take this opportunity to thank Dr. Chitra Madam for conducting a series of excellent webinars. So let's see this young boy with the VKC who was on and off steroids for 3 years, good vision, but raised intraocular pressure. So we had to start on anti-glaucoma medications. It didn't get good control, so we had to do both eyes trabeculectomy. This is not one patient. We see several patients having steroid-induced glaucoma. So the concept is, why this topic? Ophthalmic steroids are easily available over the counter. And many of the times they are diagnosed in a very advanced stage because people don't realize the seriousness of steroids. So who is a steroid responder? The older definitions have gone. Now the most widely accepted definition is if you have an IOP increase of more than 10 over baseline with also some clinical significance. When we talk about the classification, like the epidemiology, after 4 to 6 weeks of topical DEXA or betamethasone administration, the non-responders who have less than 5 are almost 60%. The moderate responders have 6 to 15 intraocular pressure, or roughly 30 to 35%. And the high responders are roughly 5%. These are the people we have to keep a watch. Sometimes, some higher percentage of normal individuals can have raised IOP if they are using a greater frequency of steroids, higher doses, and also for a longer period. So definitely genetic susceptibility is a risk factor, age, very old or very young patients, previous glaucoma diagnosis, first degree relative to open angle patients, connective tissue disease, high myopia, and also angle recession glaucoma are risk factors for steroid-induced glaucoma. This is a study we did some time back in our general units, where we see 18 to 40 years of age, 28,000 patients were screened, of which 296 were referred to glaucoma clinic, 84 with raised intraocular pressure. And if you see, steroid responders are in a bigger group in this particular group. So I'm not going to get into the details of pathophysiology, but the most widely accepted theory is that corticosteroids increase the accumulation of extracellular matrix. They also stabilize the lysosomal membrane and also increase the water binding capacity of mucopolysaccharides. As a result, what happens is there is narrowing of trabecular beams and decrease in the aqueous humor outflow, which elevates the intraocular pressure. There are several routes, but the ocular route is the most notorious to raise the intraocular pressure. So topical steroids normally at 4 to 6 weeks, they raise intraocular pressure. And if you stop at 6 weeks, within 2 weeks, that is within the 8th week, it should return to normal. So if the trabecular meshwork changes are reversible, IOP returns to normal in 2 weeks. If it is irreversible, then the IOP raise may persist up to 18 months. And there is a subset of people who can have an acute raise within a week, 10 days. We have to really watch these patients. If you see the genesis of steroids, now in 50s and 60s, we had prednisolone, dexamethasone, betamethasone, and then we had fluoromethalone in 70s. Late 90s, we had lotoprednol, and in 2000, we had difluprednate. So this is a meta-analysis which clearly shows you how dexamethasone, prednisolone, and few other steroids, the range of IOP increase is somewhere between 9 to 22. And there is a significant number who have this response. And this is after an application of somewhere from 3 to 12 weeks. And if you see the less potent steroids, difluprednate and loteprednol, does not significantly increase the intraocular pressure. The other important is intravitreal steroids. We have triamcinolone, fluocinolone, and dexamethasone. And the risk of raised IOP is more with fluocinolone followed by triamcinolone and then dexamethasone, which is biodegradable. So when you are giving intravitreal steroids for definitely people with glaucoma suspects or glaucoma, if they have pre-existing uncontrolled glaucoma, then we have to reconsider. If there are patients with IOP greater than 21 on treatment and they have slightly higher intraocular pressure, then we have to very closely monitor them by visual field testing, imaging, and also, after injections, we have to closely follow them up. If they have a good control of intraocular pressure, maybe suspects of mild glaucoma, then you just monitor the intraocular pressure. So let's say that they are on topical steroids, you want to continue the topical steroids. You try to use lower concentration, you use weaker steroids, and then you also closely monitor their intraocular pressure, or even give anti-glaucoma medication and then follow them up. So this is one work done by our resident. This is again to change practice. Do we really need steroids following an YAG iridotomy? So that was the question. So we compared, we randomized Nepafanac versus prednisolone acetate. And we found that there was a greater increase of IOP with prednisolone group as expected. More than that, Nepafanac was non-inferior. That means it was equally good. And the other important thing is the rebound iritis happened more with steroids than in the non-steroidal group. So now our practice has changed to non-steroidal in an iridotomy, and it has changed the practice pattern across Aravind. Finally, you can manage steroid-induced glaucoma like similar to open angle. Only thing, you have to reserve prostaglandin analogs in cases with uveitis. SLT can buy time in some cases, especially where you have given intravitreal triamcinolone. And when it comes to surgery, anything again in open angle, trabeculectomy and non-penetrating deep sclerectomy works well. And if it fails, shunt procedures, and that also fails, cyclodestructive procedures. Sometimes you may have to remove the repository steroid. Now in intractable glaucoma, that's an option. You remove those steroid, and at the same time, you can combine a glaucoma surgery. And also the newer procedures in the form of minimally invasive glaucoma surgery can also work in some of these patients. Thank you.
Thank you very much for a wonderfully detailed talk and a lot of information which came through. I have a question here for Dr. Vijaya. How safe are the softer steroids and why?
In the sense, how safe are topical steroids?
Yeah, which one of them?
No, see, I always tell that steroids are essential. There is no doubt about it. If it's needed, it's needed. And susceptibility to steroids in the form of raised intraocular pressure, we have to manage looking at the risk versus the benefits. The problem with the steroid-induced glaucoma, at least in our country, is that misuse of the steroids leading to glaucoma and the blindness. In clinic, which happens the raised pressure, almost 100% of the times, it is taken care and it is reversed. So the cases what we see in our clinics are mainly children and young people who keep using the steroid drops forever because they would have been prescribed for some kind of allergy. So indiscriminate use of steroids are the problem for us. So I don't stop anybody to use the steroids if it is needed for the medical reasons for treatment, like bad uveitis or any other lesion that requires topical steroids. Yes, please go ahead and use the steroids. We monitor the pressures and manage the glaucoma. That's my view as far as the steroid-induced glaucoma is concerned.
What I understand about soft steroids is that if you use a lotepred, the incidence of steroid-induced glaucoma is something just about 4%.
No, if somebody is responding to steroids, even with the FML, the pressure will go up. Even with the skin ointment, I think Venkatesh, maybe time was not enough. Majority of the times what we see in our clinics, the exaggerated steroid response are people with the asthmatics, who are on the long-term inhalers, and people on the skin lesions. They are notorious because the skin lesion is a exposed lesion, when they apply the steroid ointment, it gets into the systemic circulation. So these are all the real villains for steroid-induced glaucoma, rather than just a topical steroid which is used for a purpose.
No, I agree on that. But compared to predfort, low-tip incidence of steroid-induced glaucoma.
Yes, definitely. But if the predfort is needed for the management of the eye condition, I won't hesitate to continue with the predfort.
In this continuation, diflupred has been commonly used by many retina specialists. What is its side effects? What you people face, ma'am?
We would use it even if the IOPs are very low in the early post-operative period. Even I use it, but I think we would be careful. We'll have to titrate IOP because sometimes in these eyes, IOP goes up rapidly. I mean, I stand to be corrected. What is the experience of others? If there is hypotonia in the immediate post-op period, I'm sure some of us do use like diflupredate.
Can I just add something?
Yes.
So I think that the steroid-induced glaucomas will continue to bother us still for a very long time to come. But one important thing that I'd just like to point out is that there's a very high risk of developing glaucoma even with just a little bit higher increase in axial length. That is, myopia is a very big risk factor. And all patients, one should consider that all patients of myopia, be it mild myopia or moderate or high myopia, one should consider that they are all steroid response unless proved otherwise, actually. Which means that if you operate on a myopic patient, let's say someone has an axial length of 25 or 26 millimeters, and you operate on them and give them post-operative steroids, and that's quite justified because you've done a cataract surgery. But please watch out for an elevation of intraocular pressure. So I think that's very, very important that when we have a myop in front of us, we do everything to assess the intraocular pressure if we give steroids.
True. Does GAT have a role in this steroid patients with steroid IOP is very high and you want to do some surgery? Dr. Shushmita? No, she's not there.
Ma'am, unmute, please.
Yeah, sorry. Yeah, so a lot of them would be reversible once the steroid is stopped. So surgery would not be the first. We would consider surgery only if there is persistent raised pressure and there's optic neuropathy despite discontinuation of steroid. And yes, GAT would, I think, logically work because the outflow channels are okay. And if you remove trabecular meshwork, but maybe you could do something short of a 360 degrees as was being told. But a lot of them, by the time they require surgery, again, the problem is that, it's 40 pressures, it's a total cup. And in a condition like that, I would not be wanting to do minimally. Just one point about the so-called softer steroids. I think the thing is that they don't penetrate. And because they don't penetrate, they don't raise the pressure so much, but they also don't work as well. So
but
if you really want
breached, then all of them are on the same boat, I think.
Yes. So intraocular inflammation do not respond to lotepred or FML. And therefore, the steroid responsiveness would not be there. So if you require it for intraocular, you require something that goes in, and then the steroid response is higher.
Thank you very much. We shall now go on to our next speaker, Dr. Rashmi Murthy, who is a consultant ophthalmologist from L.V. Prasad Eye Institute at Hyderabad. And she is going to be talking on bleb-related infections and endophthalmitis. On to you, Dr. Rashmi.
Good evening, everyone. At the outset, I would like to wish Happy Sankranti to all.
That was the best thing you did. I should have done that before.
And Dr. Chitra for giving me this opportunity. So we all know that trabeculectomy is a conventional filtration surgery that we have all used, and there are so many all the topics have been covered about this. So we basically create a conjunctival opening and a scleral flap opening. And most of the times it does work well, and our results are good, around 80 to 85% success rate in primary glaucomas, and they do relatively well in secondary glaucomas too. So the problem occurs in few eyes when we see these complications. Sometimes they are mild, sometimes they're very serious. And the most rare but very serious is this, which is bleb-related infection and endophthalmitis. Coming to my case, he was a 16-year-old boy who was referred to our Institute for IOP Control. He complained of gradual diminution of vision in both eyes since 3 years. He was already on 2 medication with oral Diamox. Systemically and other history were not contributory. His visual acuity in both eyes was 20, 30, and 10, which was getting corrected with -2 dioptrosphere. Anterior chamber, both eyes had shallow anterior chamber, clear lens with minimal phacodonosis. Gonio showed occludable angles with more than 2 angle goniosyneche and RAPD in the right eye. Cupping was advanced in both eyes with high intraocular pressures in both eyes. So the first thing that comes to our mind when a patient with young age myopia and angle closure glaucoma is spherophakia. Because lens was not small in size, we only say it as spherophakia and not microspherophakia, but there was associated angle closure glaucoma. We did laser peripheral iridotomy in both eyes and added medication, but in spite of that, the pressures were not under control. So we went ahead and did limbal-based trabeculectomy with mitomycin C under GA. And primary anterior chamber reformation is something that we do as a routine in spherophakia eyes. And in the right eye first, and then followed by the left eye with a gap of 3 weeks. Right eye was uneventful and the IOP was well under control. When we come to the left eye surgery, on day 1, the pressures were very low with a diffuse overfiltering bleb, very shallow AC with a lenticular-corneal touch. So because of that, it did not improve the next day also. So we went ahead and did an AC reformation, but because the AC was not forming even with air, we opened the bleb area and put extra sutures to decrease the filtration, and we additionally put some glue to decrease the filtration. But 2 days later, the patient presented with severe pain in the eye, hand movement vision, lid edema, discharge, and conjunctiva was markedly injected. So if you see that there was a lot of discharge in the eyes and the conjunctiva was congested, and the area of the bleb, this is intraoperative photograph. So the area under the bleb was showing a yellowish hue. So the discharge which was there at the lid was taken and it was sent for microbiological examination. And then first we could see that there was some pus at the area of the conjunctival wound. The sutures were cut, the 80 vicryl was cut. And then we saw that once the conjunctiva was opened, there was copious mucopurulent material that came out of the area, which was aspirated and sent for microbiological examination. Surprisingly, we saw that the conjunctival edges and the underlying sclera was not necrotic, that was healthy. We put additional sutures to decrease the filtration because we did not want any communication between the bleb area and the eye. So in fact, the eye was white and there was no pus in the antechamber, or the fundus was also, the view was good. So it was just a localized bleb infection. We put a scleral patch graft and then close the conjunctiva with interoperative sutures. Because we had totally closed the filtration, we did not want to put this suture as a watertight suture, because if there was any additional pus that could drain through this openings that was there. So we did not put a watertight suture. So then the gram staining revealed gram-positive coca and the culture revealed Staph aureus, which was susceptible to cefazolin. So initial 5 days we gave intravenous antibiotics and then continued topical fortified cefazolin for 1 month. This was the appearance at 1 week, where the bleb area was healing and the AC was still shallow, but there was no evidence of any infection. At 1 month, the AC had improved. This was at 2 months, the bleb had totally scarred, but the IOP was under control. So I suppose there was some filtration occurring in that area, but there was no evidence of any infection. The patient had developed an anterior subcapsular cataract through this course. This is another patient where in the area of the releasable suture, there was corneal suture infiltrate. So basically, it was sensitive to cefazolin and we treated with cefazolin. So to summarize, bleb-related infections are less common without the use of MMC, which is 0.2 to 0.5%. But with the advent of MMC, the incidence has increased, with the risk factors being young age, Phonics-based incision, bleb leaks, thin neovascular cystic overhanging bleb, use of releasable sutures, and diabetes. Early blebitis less than 1 month, most commonly caused by Staph aureus, which is similar to acute post-op endophthalmitis. And usually occurs after 1 week. Basically, we treat with systemic and topical antibiotics empirically and then based on the susceptibility. If it is endophthalmitis, it is more severe and site-threatening, pars plana vitrectomy and intraocular antibiotic. And then based on the susceptibility we treat, the visual outcome is poor with virulent bacteria like Streptococcus and coagulase positive, but the benign course with coagulase negative staph. So the pearl is that if it's a high myope, young age, shallow AC, it's a spherophakia just for the postgraduates.
So 1 minute remaining.
Bleb-related inflections are rare, but they are site-threatening following trabeculectomy. Timely management is very important based on whether it is localized or endophthalmitis. Localized blebitis have better prognosis, and endophthalmitis is vision-threatening. And risks and benefits of mitomycin C augmented trabeculectomies should be taken into consideration. Thank you.
Thank you very much. Just one question to you before we go on to our next speaker, a very simple question. You've told us how you would treat a blebitis without vitreous involvement, but do you think even if you have managed it early, there are chances of the success rate of the bleb functioning is a possibility at all?
Early bleb infections, like only blebitis, they do work. So personally, this is the only patient that I've seen when I was a fellow and I've been doing my traps, but it is very, very rare condition. So endophthalmitis, I think, does not have a very good visual potential, but just blebitis and bleb abscess, they do have good potential. But this patient did well even after we closed the trabeculectomy site. In spite of that, the pressures were under control. So we do suppose that there was some filtration that was going on, and he did very well after that.
Dr. Vinay, you have, Rangya, have anything to add?
No, I think that, if the bleb continues to function and the pressure continues to remain in control, then I think we should just, thank that's how it is actually. So, but I think she was very fortunate that, it really didn't get into the vitreous. There was so much pus that one would have anticipated that little bit trickle into the vitreous minute. But I think she was extremely blessed actually not to have faced that.
One question to Dr. Rashmi. See, many times we see very thin-walled bleb post-mitomycin C surgery. So we are scared whether to touch or intervene because it is working fine. But there is always a potential for infection if it's a person coming from a far-fetched village or somewhere. So do you really need to intervene? That is one. Second is the early bleb infection. Like the source can be just like a cataract, touching eyes, or the swimming, or any cosmetics. So what all could be the causes that you found during the early blebitis and compared with the other aspect?
Yeah, for the first question, I feel if the bleb is very thin and cystic, but there is no hypotonia or there is no bleb sweating that we say, then I think we can just leave it because there is an epithelium which is covering it. But if there is a bleb sweating, that means if when we stain, there'll be some areas of pinpoint leaks that happen, then I think we should go ahead and repair such blebs to prevent future infections. We have published a case series on that too. The second one, early bleb infections, is just like our cataract surgery infections. Like if there is any issue with the hygiene, or if there is an issue with the instruments that we use or the fluids that we use. So we were actually suspecting that the fibrin glue that we used might be a source for the infection, but we did not find any evidence for it. But it is not very common to have early bleb infections. One report I read on releasable suture causing as a suture tract causing the bleb infection. But most commonly are late infections that have been reported.
Thank you. We shall now go on to our next speaker, Dr. Vinay Gupta, who's Adjunct Professor of Ophthalmology at All India Institute of Medical Sciences, and he is going to be talking on a case of a pediatric glaucoma and how it was managed. On to you, Doctor.
Thanks, Dr. Chitra, and I must thank the AIOS for inviting me to talk on this subject of pediatric glaucomas. So I'm going to talk to you about this little child who was brought to us at 1 month of age, and this was a typical presentation of the child having large corneas, a hazy appearing cornea with photophobia, watering, But what was interesting about this family that we later realized, and which we realized about 2 years later, and for the postgraduates to understand, is that he had a cousin sister who was also affected. So this is this particular child and a cousin sister who was also affected. And this history we came to know 2 years down the line, once the child was okay and was behaving well after surgery, that they were actually both related to each other in the sense that there were two sisters married to two brothers in a remote village in Rajasthan. So here was a family where two siblings had congenital glaucoma. I'll go on to this case later on. But when you have a child who has pediatric glaucoma, you must understand that the first thing is you have to establish the fact that there is glaucoma, and so you have to measure the intraocular pressure. And in children, generally, the intraocular pressure is much lower than in adults. So when you have a high intraocular pressure, let's say in a 2-year-old child, which is about 22 millimeters of mercury, you have to be getting a little worried. The next important thing is, how do you measure the intraocular pressure? So generally, the children are under anesthesia, and when there is anesthesia where the child is undergoing, there is some amount of lowering of intraocular pressure. So the measurement of intraocular pressure may be at least 2 to 5 millimeters lower than what it actually is, and this has to be taken into account when you are writing the intraocular pressure. Most of the anesthetics decrease the intraocular pressure except for ketamine, which is supposed to cause a slight rise of intraocular pressure. So as an alternative to anesthesia, there are other ways by which you can measure intraocular pressure. You can sedate the child using triclophos. You can have the child sleeping naturally and then measure the intraocular pressure. And in some older children, you can actually allow them to cooperate and then measure the intraocular pressure, which is the most physiological thing. So apart from intraocular pressure, the other important thing to understand when you are diagnosing or suspecting a child of having glaucoma is to know the axial length, because the axial length is very sensitive to intraocular pressure changes, and only a slight change of intraocular pressure can cause a significant change in the axial length. And if you know what are the axial length at different times of a child's life, then you will understand that this axial length is outside normal limits for that particular child's age. Regarding management of these children, medical therapy remains only a kind of a stopgap. And apart from pilocarpine and prostaglandins, which are generally considered safe, there are problems with other drugs, and you have to consider that when you're giving medication to these children. For example, beta blockers at a very young age, you have to reduce the concentration so that you do not get into apneas and obstructive diseases in children. But surgery remains the mainstay of management of pediatric glaucomas, which are generally, when I say pediatric glaucomas, I hear by mean primary congenital glaucomas. The surgical options in most of the cases, in milder cases, you can get along with doing a goniotomy or a bang. But in a more severe or advanced case, like in this particular child, for example, we had to do a trabeculectomy with a trabeculotomy. So you have to combine them. The results are spectacular, and for postgraduates, you can see almost the cornea totally clearing up in most of these children. Even more spectacular is the optic nerve coming back to its normal configuration from a cupping to a normal looking optic disc. But what remains is the harp striae in the cornea, which do cause some amount of photophobia in these children and amblyopia over a period of time. You have to follow up these children lifelong. You have to do their visual acuity, multiple refractions. You have to manage their strabismus, amblyopia. Some of these children may also develop cataract and may require a keratoplasty. Because these eyes are big, you may have to do a good retina evaluation as a child grows up, because generally they behave like pathological myopes and have a very high incidence of retinal degenerations and retinal detachments. So this was a 25-year follow-up of our series where we have followed up these children for long. And what we realized is, as far as visual outcomes was concerned, amblyopia or a lack of management of amblyopia over the years is one of the main causes of why these children do not get good vision. So even if you've done a good surgical job, the intraocular pressure is well controlled, but the visual acuity will not improve if they are not given adequate refractive correction and managed for their amblyopia. So coming back to the same child, This is how the picture is after 1 year of surgery. This was the picture when the parents brought the child, and the child is now happily moving around and playing about. So this is the story of almost like 80 to 90% of these children. And this is what the postgraduates have to realize, that there is a lot of scope in pediatric glaucomas, and they can do pretty well. But the next important thing is to counsel, not just counsel the parents regarding the long-term outcomes, but as in this case, you may have to do a counseling for the next child that is going to be born, and the parents, even if they're coming from low socioeconomic status, will have to be told that what are the consequences of the next child having glaucoma, and that can only be done when a thorough genetic testing of these children is done. For example, in this particular family, we did actually go ahead and do a genetic testing for the child. So to sum up, I would like to say that this pediatric glaucoma has great scope, and it is a good option in managing these children, and they do pretty well. We have this conference coming up, and those who are interested, in March this year, we'll have a virtual meeting of our Indian Pediatric Glaucoma Society. A lot of us have worked very hard in bringing up this program, and you're all invited to join in. Thank you.
Thank you very much, Dr. Vinay. I'm going to ask you this question. What do you think is the role of GAT or a 250-degree goniotomy in these eyes?
Yeah, so as I said, you see in very early cases where the cornea is relatively clear, where the optic disc is not so bad, these are the children who can undergo a goniotomy or even a GAT, you see, and they will do pretty well. Whereas children who have a very large corneas or a very advanced disease or a very advanced cupping, these are not the candidates for a GAT or a goniotomy, primarily because you want low intraocular pressure in these eyes. You want that optic disc to reverse, and you want it for a very long period of time, which means that you would like to do something definitive. And these are the cases where a trabeculectomy with a trabeculotomy would be a better option to go ahead with.
Dr. Shushmita, any thoughts on this? Anything you want to add?
Yeah, and it's also important to understand phenotypes, the ones that do, because pediatric glaucoma is a basket of very, very different things. So if you have a phenotype, say, the neonatal onset glaucomas don't do too well. And I think primarily because the dysgenesis is early in utero and the outflow channels have not developed. So that's how we understand that the angle surgeons don't work too well, and you might have to combine them. And then phenotypes like aniridia, especially if they're neonatal onset, they don't do too well. Neonatal onset CU doesn't do too well. The best candidate for angle surgery would be an infantile primary congenital glaucoma. There's no doubt about that. But mercifully, they make up more than half of our armamentarium. So if we can see it but phenotyping is very, very important. My take on that.
Thank you very much. Paucity of time, we need to move on, and we have a next eminent speaker, Dr. Vijaya, and she's going to be talking on a complex topic, eye syndrome. On to you, doctor.
Yeah, just 1 minute. I'm not able to share the.
Maybe you could stop sharing and share again.
I got.
Yeah.
So at the outset, I would like to thank AIOS ARC, especially Chitra, for this kind invitation and very that's very educative for everyone. So I will be talking to you on eye syndrome. So eye syndrome, iridocorneal endothelial syndrome, is usually unilateral. It is a rare progressive disorder with a broad spectrum of clinical manifestations, characterized by corneal endothelial abnormalities with varying degrees of corneal edema, iris atrophy, secondary angle closure. So there are 3 clinical variants for the postgraduates to know about it. And one is the progressive iris atrophy, where the changes are mainly in the iris. And the second one is the Chandler syndrome, where the changes are mainly in the cornea. The third is the Cogan-Reese syndrome, characteristic of very small nodules on the iris surface. There can be overlap stages between the 3. The etiology is not very well known, but majority believe that it may be of the viral etiology. And most of the times people were able to isolate the virus-related substance from the aqueous tap which was taken at the time of the surgery. And most of the time it is herpes-related etiology. Coming to the symptoms, most early stages it is asymptomatic, and with the time the people will develop pain and blurring of vision due to the corneal changes or elevated intraocular pressure. And many patients will complain of change in the pupil size and the position. Signs are increased myopia, microcystic corneal edema. Corneal endothelium will have a characteristic fine hammered silver or beaten bronze appearance. Iris changes can be heterochromia, ectropenoia, polychoria. Gonioscopy characteristically shows angle closure. Specular microscopy will have abnormal large round pleomorphic cells with the typical light dark reversal. And in cognaries, you will see nodules like what you are seeing here. And treatment is, people start with the medication, but usually very poor prognosis in spite of maximum medical treatment. IOP control is poor because there is high failure rate with the surgery. Tube is preferred surgery in this size. Often this size will need even ciliary ablation. Here is a case of ICE syndrome managed by us. 49-year-old male complaining of pain in 2 months, diagnosed as ICE syndrome 10 months back. Intraocular pressure was 34 millimeters of mercury, was on maximum medication, and the pressure was not under control. This is the clinical picture. It fits into Chandler's. You can see the beaten silver appearance of the corneal endothelial surface. So they decided to do the surgery for this patient. The choice is again the tube. AGV was done. The challenge is because of the extensive synechiae and being phakic, where to put the tube. So this surgery was done by my colleague, Dr. Parivadini, and the superior nasal quadrant. The AGV was positioned. So after securing the plate, and an iridectomy was done first using a limbal incision, using the light pipe, and 2 millimeters away from the limbus, and a track was created for insertion of the tube into the sulcus. And light pipe is a good tool intraoperatively to visualize a hazy cornea. And using that, tube was inserted into the sulcus, and you can see, and it comes out through the PI. That is the purpose of the PI, so that you can insert the tube into the sulcus. So this follow-up at 6 weeks, you can see the well-placed tube. Pressure is under control. Vision was 6/18 with 1 AGM. Pressure was 10 millimeters of mercury. And at the follow-up of 1.4 years, the intraocular pressure is maintained, but the vision reduced because of the progression of the cataract that needed intervention at a later stage. So in general, eye syndromes don't do well. Majority of them will progress or worsen with the time. And unfortunately, majority of the patients also present to the clinic at a very late stage because they are not aware that they have the problem. The endothelial proliferation that keeps happening contributes to the failure of the surgery. So when the tubes doesn't work well, one may have to resort to the ciliary ablation. Thank you. Thank you very much.
Thanks a lot, Dr. Vijaya. I mean, your topic was so complete. I don't have questions. A tube is the only way to go. And of course, you would suspect it more commonly if it's a unilateral presentation and a middle-aged female are the common presentations. And of course, all the signs you said. Any question from the expert panel, or should I go on to the last 2 speakers? Dr. Shushmita.
Is there any role of trabeculectomy, especially in phakic patients with shallow AC? Do you ever do trabeculectomy?
You can do it, but the failure rate is very high. So that is the reason we started directly going for tubes rather than doing the trabeculectomy.
Can I add a couple of points?
Yes, yes.
You know, I completely agree that that going for tube as a primary surgery is probably the best thing to do because of the failure of a trap. But even with a Ahmed's glaucoma valve, sometimes, you know, it doesn't really bring down the pressure in every single patient. And that, you know, that's really very upsetting. The other important thing in these patients is because of the endothelial proliferation, when these patients do develop a cataract, then there's a very high chance that, you know, the cornea will go for decompensation, if not immediately, then over a period of a few months or a year or 2 years. So it's a real challenge dealing with these patients, actually.
Yes, thank you. That was a very valid point. We shall now go on to our next speaker, Dr. Anil Mandal, a very famous personality and who is a senior consultant in the Child Eye Care Center at LVPI Hyderabad, and he's going to take a difficult topic, aniridia. On to you, Doctor. Can you unmute yourself? Dr. Mandal? We can't hear you. Yeah. Yes. Can you, you've unmuted. Yes. Yes, yes. You can start.
Is the slide visible?
Yes.
Am I audible? Am I audible?
Yes, yes.
So thank you for the opportunity. I take this liberty to present a management strategy for glaucoma in aniridia rather than presenting a single case. Aniridia is a very difficult type of glaucoma with a developmental basis. PAX6 mutation is the most common mutation, and the associated features are cataract, glaucoma, keratopathy, and optic nerve or macular hypoplasia. This is a typical picture of aniridia. The term aniridia is a misnomer. Each and every patient of aniridia will have a short iris stump. This patient we managed by primary combined trabeculotomy, trabeculectomy. I'll come to the presentation later on. You can see the gonio anomaly here. Even though aniridia, you can see the short iris stump as you can see in this clinic here. And that's the reason management should be done and the iris stump should be managed in trabeculectomy surgery. I'm presenting few important slides to depict peculiar anatomical changes. Here is a patient who has aniridia with cataract and a very rare finding of circular pigmentary line behind the lens, which is classically seen in pigmentary glaucoma named as Gentmeyer's line. Under the two illuminations showing the same picture here. In my 30 years of practice, I have seen this kind of picture in 2 patients with congenital aniridia. A very advanced stage of the disease giving rise to dry eye along with limbal stem cell deficiency. The other eye of the same patient, aniridia associated keratopathy and fundus two illumination showing extensive vascularization of the cornea. Here is a patient who presented to us for management of aniridic glaucoma, and the patient had history of nephrectomy. It's a case of Wilms tumor and aniridia. The mechanism of glaucoma in the early stage can be related to angle dysgenesis, as we see in primary glaucoma in children. But in late onset disease, it is the peripheral iris stump giving rise to peripheral anterior synechia formation, jeoparding of the angle. Here is a patient who presented to us with congenital onset developmental glaucoma associated with aniridia. You can see the lens margin, you can see the ciliary process. This is the kind of situation we prefer to perform primary combined trabeculotomy and trabeculectomy. We published recently a paper where 18 years of collection patients of early onset glaucoma who underwent combined trabeculotomy, trabeculectomy. By early onset, we mean patients who were operated within 3 years of age. Primary surgical technique was combined trabeculotomy, trabeculectomy without any antimetabolite, and data was collected on retrospective chart review. 2 surgeons were involved in the surgical technique. In some cases, Schlemm's canal was not identified, and that's the reason only trabeculectomy was done. We do not believe in using intraoperative mitomycin C in primary surgery in congenital glaucoma, and here is a series where all the patients were done without any antifibrotic therapy at primary surgery. The outcome measures were defined before the data analysis. Complete success was defined intraocular pressure 5 to 21 millimeter of mercury with no medication, and when medications was used to control the intraocular pressure, it was in the category of qualified success. Statistical analysis was done. 76 eyes of 42 children were initially identified, of which 35 children were included, giving rise to 66 eyes where combined trabeculotomy, trabeculectomy was done. This is the demographic data. I'm not going into the details of the paper. Here is the percentage of eyes in a line graph diagram showing intraocular pressure more than 21 millimeter of mercury over different time limits. The success rate was defined with cutoff value of 21 millimeter of mercury, and in another definition, we took cutoff value as 16 millimeter of mercury. Again, when we took 16 millimeter of mercury, intraocular pressure control was achieved without any medication, and at the end of 1 year, success rate was approximately 81%, decreased to 68% at the end of 6 years, and by the 10th year, success rate was 63%. In patients where primary surgery failed, these are the patients which were not included in the primary analysis. These were after trabeculotomy, trabeculectomy, additional surgery performed. Glaucoma drainage implant, Adi implant was done in 1, Ahmed glaucoma valve in 1 eye, repeat trabeculectomy with mitomycin in 2 eyes, and transscleral cytophotocoagulation was done in 3 eyes. Here is a patient. We did combined trabeculotomy, trabeculectomy in the right eye, and left eye intraocular pressure was controlled with 1 medication, and there was no corneal edema. We are following this child. This child was having macular hypoplasia. The bleb appearance of this child photographed at 6 months postoperative. Here is a patient we initially operated for trabeculectomy with mitomycin C in the year 1995. The child was doing all right till 10 years. After that, cataract developed. Cataract surgery was performed sequentially in right eye, then the left eye. Elsewhere, we used to see this child on regular follow-up. When the cataract developed, cataract surgery was done elsewhere and was doing well, but later on developed corneal bleb infection and endophthalmitis, which was managed elsewhere. And when we saw the child was having no perception of light.
1 minute remaining, sir.
Right eye. And left eye was having good vision, 20/60 without any anti-glaucoma medication. Here is the patient. The right eye ultimately underwent evisceration with implant, and later on fitting of artificial eye, that is prosthetic eye. We have had the experience of following this child for about 28 years. So this is the management strategy. the study limitation so far, primary combined trabeculotomy was done, is written here. And in anaerotic cases, I feel as a primary option in congenital onset or early onset within 3 years, combined trabeculotomy can be the first option of management. Thank you.
Thank you very much. Wanted to just ask you one question before we go to the next speaker. Is there a role of doing a prophylactic goniotomy in this condition?
Yes, can I answer that?
Yes, Doctor.
Prophylactic goniotomy, the advocate is Dr. David Walton. Now, he published a large series in Archives of Ophthalmology in the year 2004. Some of his associates believe in that, but prophylactic goniotomy, where at presentation cornea is clear and there is no glaucoma, there is no optic disc change, no evidence of glaucoma, I mean, but by total evaluation, very few surgeons will be advocating that. I have consulted and in fact visited Dr. David Walton for twice for a series for about 1 week each time. I have seen some patients he used to do prophylactic goniotomy, but I don't think any expert is doing that kind of approach.
But I think in a sporadic aniridia, doing a Wilms tumor screening makes sense, I suppose.
Yes, it is very important from the medico-legal point of view also. If we do not really advise proper evaluation, ultrasound abdomen to rule out renal tumor, later on if it is detected, and in fact it's not a one-time job, periodic checkup according to the requirement, it should be done. Otherwise, it falls into the category of medico-legal issues in the future.
Thank you so much for your contribution, Doctor. Thank you so much. We shall now go on to our last speaker, Dr. Sunita Dubey, and I'm so sorry that you're the last speaker and you've been unwell, and the way you sat through it and gave your expert views. I'm so thankful to you, and let us hear your very interesting talk on an overview of glaucoma drainage device and their complications. On to you, Dr. Sunita.
Can you see my slides?
Yes.
Yeah, so thanks a lot, Dr. Chitra, for having me for such a wonderful and extensive webinar. As you know, glaucoma drainage device surgery has become one of the most commonly performed and dependable glaucoma surgical procedures, especially for secondary refractory glaucomas and even in some complex primary glaucomas, with significantly improved long-term outcomes with better designs, material, and technique. A thorough pre-operative evaluation is a must, and a meticulous planning for surgery is a must before going in for glaucoma drainage device surgery. One needs to assess for associated comorbidities like uveitis, neovascular glaucoma, previous complicated surgeries like VR surgery, squint surgery, which may be associated with scarring and may affect the type of the implant and the site of implant. And also the presence of associated comorbidities like vitreoretinacea or neovascularization or inflammation needs management of the primary pathology to prevent post-operative complications. Also, the two very important determinants for deciding the position of the tube are the extent of PAS and the status of lens, and they're going to decide if they are going to put the lens in the tube in the anterior chamber or in the sulcus or in vitreous. I will discuss here this post-PK glaucoma, a young male who underwent penetrating keratoplasty recently, and he came to us with a clear graft and with very high pressures. And as you can see, there's an extensive PAS 360 degrees and IMSC and a near total cupping. He was not controlled with maximal medical therapy except glycerol and mannitol, and we decided to do phaco with IOL with AGV. So I feel in such complex glaucomas, a combined procedure is a boon, and the cataract surgery was performed with the temporal incision. The pupil, as you can see, was already dilated, and the cataract surgery, the phaco was done, and the intraocular lens implantation was done. And then the superior temporal quadrant was chosen for the AGV implantation, and After priming, the plate was fixed 9 millimeter away from the limbus. I use 90 nylon suture for the fixation of the plate, the tube fixation, and also the scleral patch graft suturing. Sorry. So since there was extensive PAS, the tube was planned to be put in the sulcus. Viscoelastic was injected while inserting the needle so as to dilate the sulcus, and then tube was inserted into the sulcus. And since the pupil was already dilated, the length of the tube is such that it was visible through the pupillary area. So the tube was fixed with nylon suture again. And then this scleral patch graft was used to cover the tube. And then the conjunctiva was sutured. So this is the post-operative picture, and this patient is doing extremely well 4 to 5 months after surgery with the IOP well controlled. So post-operatively, like any other glaucoma surgery, you have to use steroids, antibiotics, cycloplegics. One needs to monitor for the hypertensive phase, especially in the valve implants, and hypertension or low IOP can be there in the immediate post-operative period. It could be because of peritubal leakage or malfunctioning of valve implant or oval filtration or incomplete occlusion of non-valve implant device. So it's very important to take care of all these factors, and it could be because of some non-device related complications like severe inflammation, choroidal detachment, or cyclitis. And as in trabeculectomy, the hypotony is more common in patients with myopia and view ophthalmic eyes. But if sometimes, if it is transient in most of the patients, it can be controlled with conservative treatment. Non-valved implants, the valve implants are associated with hypertensive phase, and it begins as early as 2 to 6 weeks and may last for 4 to 6 months and resolves with remodeling of bleb. And as we know, the cause of this hypertensive phase in valve implant is early exposure of conjunctiva and Tenon's capsule to aqueous with pro-inflammatory cytokines, inducing early fibrosis and scarring. And there can be other factors too, like multiple surgeries or the smaller size of end plate or polypropylene rigid plate. So aqueous suppressants are now widely prescribed to prevent hypertensive phase. And if you start aqueous suppressants early in the course of post-operative period, then you can prevent hypertensive phase to a large extent. And then other procedures like bleb needling, removal of cyst wall and all are not so effective in case of implant surgery as in case of trap. A very simple procedure is that you can just tap the bleb using 30 gauge needle on slit lamp or to release the tensions of these high tension bleb, although you need to do it several times. It may alter remodeling of the bleb, but results are unpredictable. Coming to complications, the implants are associated with a unique set of complications which are related to implants like outflow obstruction, conjunctival erosion, implant exposure, tube migration, or diplopia. In the early post-operative period, since we are doing complicated cases, it may not be uncommon to see the proximal end of the tube being blocked by blood, fibrin, iris tissue lens, or vitreous. And it may be transient and it can retract, especially blood and fibrin with topical steroid and cycloplegics. And even iris strands and vitreous strands, if they're small, can be managed with low energy YAG laser spots. But in some cases, a surgical intervention may be required. So in this particular neovascular glaucoma patient, a low energy laser shot could retract the clot, as you can see, and in another patient too. So most of the times it can be managed with conservative treatment. If the tube is in close proximity to the iris, and if there is iris incarceration, it too can be managed with a low energy YAG shot, as you can see here. Vitreous, if it is a thin strand, then can be cut with YAG shot. Otherwise, one has to do vitrectomy. A common complication which is present in 2 to 8% of patients with tube implant is conjunctival erosion or wound dehiscence. So wound dehiscence occur early in the course of post-operative period, and the tube erosion occur little later. And this conjunctival erosion, if the conjunctiva is relatively healthy, then can be treated conservatively. And doxy does have a role with a lot of lubricants and steroids, and the conjunctiva can get epithelialized over a period of few weeks. However, if there is tube erosion, then immediate intervention is required because there is a risk of endophthalmitis. And tube erosion generally occurs in patients who do not have a very healthy conjunctiva, or there is excessive tension overlying the tube. It could be because of immune-related inflammatory process or repeated mechanical force caused by eyelid blinking and rubbing. And that is why it is can be seen in children as well. The long scleral tunnel technique can prevent it to some extent, and also the tube which enters the eye at 12 o'clock rather than at 10 to 2 o'clock can prevent tube erosion to some extent. But if the tube erosion happens, it has to be treated surgically. You need to dissect the eroded conjunctiva, fix the tube to the scleral bed, and when you suture it, it lies flat on the scleral surface, and which prevents the movement of the tube. Patch graft, either scleral or any other patch graft, can be used to cover the tube, and the conjunctival advancement if the conjunctiva is not necrotic. But if the conjunctiva is not healthy, then you need to use conjunctival pre-graft or autograft, and the pedicle graft if the conjunctiva is thin, scars, or avascular owing to numerous previous surgical procedures, because the pedicle flaps allow the importation of distal vascularized tissue to the area. Sometimes you have to use amniotic membrane grafting with fibrin glue to put everything together. Post-operative hypotony can also be commonly seen in patients because of various reasons, and a very simple technique wherein you can just put an intraluminal stent. You can use a 3-0-proline or 4-0-proline in this particular patient who had undergone multiple surgeries and even cyclodestructive procedure before this tube implant, had severe hypotony. So 2 stab incisions are made. One is opposite to the tube and the other adjacent to the tube, and then with the help of microforceps, grab the tube and insert this proline suture into the lumen of the tube. This is 4-0-proline, and it doesn't completely block the tube, but maybe 65-70%. If you want to completely block, you use 3-0-proline suture. So to conclude, meticulous preoperative workup and surgical technique is a must. Frequent follow-ups to recognize the early complications. You need to recognize the hypotony, you need to recognize the hypertensive phase, and manage them in time to improve long-term success of your surgery. Thank you very much for your kind.
Thank you very much, Dr. Sunita. That was a wonderfully amazing talk. We always keep for the best for the last. So I would want Dr. Shushmita to also be involved in the 2-3 questions I'm going to ask her. How do you prevent or manage entry site leaks with the glaucoma drainage devices?
So, okay, sorry. Sunita, go ahead.
Go ahead.
No, it's okay.
Okay, so I think using a 25 gauge needle, even though it sort of is a little tricky to get the tube in, but that's the best. But having said that, I must confess that I find it very, very difficult. So it's easier to go in with the 24 gauge, but in that case, I would use a longer track, a longer scleral track, rather than enter right at the limbus. And the other thing is sometimes the tube entry at the end of the day is the most tricky thing, because somehow it never goes where you would like it to be. It goes everywhere else. The other small trick that I've learned from Ronnie is to enlarge just the inner part of the incision, and then the tube sort of, it funnels inside rather than outward, and that again. And the third thing that has helped in insertion is using viscoelastic and injecting it while coming out. So lubricate the passage so that it goes in. But otherwise, you just keep doing it.
Have you ever implanted a second GDD, or have you tried doing a needling for a failing drainage device, though?
We used to need to, in fact, do capsular excisions, because with the AGB, especially in young patients, but ever since the ADI has come on the block for young patients, I don't need to do any excisions after that. And the excisions never work. Within the period of 4 to 6 weeks, they come right back. And yes, sometimes I have implanted a second drainage device, but only after I have exhausted multiple DLCPs with transillumination. But rarely I have had the occasion to do that.
So one thing I have observed is if you have used DLCP and if you again do another glaucoma surgery, then the chances of ciliary body getting compromised or it's not optimal. So the chances of hypotony is much more. I showed in my last case that the patient had undergone transscleral cytophotocoagulation, and after doing this AGV, she went into hypotony. So I think.
Is there a special implant size in children?
By the time a child requires a drainage implant, it's usually ophthalmic and we don't need to. So I've never put a smaller plate. I haven't needed to.
Or maybe you could trim it also, I suppose.
I think as our hair grows grayer, GDDs in children is a bad idea. I mean, they do well for 6 months, 1 year, but you follow them long enough, they rub. So there's nothing you can do with a child. He's going to rub. I've had erosions, and now I've become more and more conservative in children, frankly.
Any other question from the other speakers, or shall I go to my conclusive remarks? I'm very sorry we are ending it later. I suppose there wouldn't be any questions, and I'm so sure that we all agree on one score, that it has been a truly wonderful webinar, and I learned a lot. I'm not sure about all of you. And on behalf of ARC, a most heartful thanks to the very expert panel and a truly superb set of speakers. My thanks are due to Dr. Shailesh, who was such a supportive partner, and he gave me so much energy along the way. And my thanks are due to my ARC panel too. Thanks to Mr. Kripal and the AIOS team. Thanks a lot, Sai and Manjula, for the innumerable mails you helped me to shoot to all the AIOS members. Dr. Anand Sethi, I goes without saying, all of us in these webinars know how efficient he and his team is. And my most heartful thanks to Sun Pharma for sponsoring all our PG update related webinars. And finally, and most importantly, my thanks are due to our very dear attendees for making it so worthwhile. Thanks a lot, everybody. Thank you so much.
Thank you.
Thank you.
Thank you, Dr. Shailesh. Thank you. Thanks, everybody. Thanks, Dr. Sunita.
Speedy recovery, ma'am. Speedy recovery.
Speedy recovery, yeah. Thanks, Dr. Shishmita.
Thank you. Thank you. Thanks, everybody. Good night.
Everybody.
Thank you. Bye. Good night.